awareness about this disease, improve access of cancer care in India, and provide an empathetic care regime for patients that covers their emotional, financial, and health needs. Right now, in the middle of a pandemic, the attention is on the coronavirus and the devastation it has caused around the world in the north. According to the WHO. It is estimated that at least one third of common cancers are preventable. To create a future without cancer, the time to act is now. We all need to unite in our efforts to fight cancer. IHW Council has been at the forefront of advocacy for cancer awareness, as knowledge and early detection is the best defense against the disease, whose burden in India is projected to grow to 1.57 million by 2025. The corona pandemic has disrupted early diagnosis and treatment. Cancer patients have been reluctant to step into hospitals for treatment as they have a compromised immunity and are at a higher risk of contracting the virus. For the same reason, patients who suspect something is wrong have waited for a better time to approach a physician. But the truth is that early diagnosis is the best defense against cancer. Many types of cancer are curable if caught and treated early. The irony is that in India, the mortality rate of cancer remains fairly high. As much as 70% of patients in our country present themselves in the late stages of the disease, and which is why the mortality rate in our country is pretty high. Over the last 2 years of the pandemic, IHW Council has worked to address the information gap through a dedicated cancer care talk show. Every session of the show brings a specialist to allow cancer patients, their families, and the people in general to get evidence-based information. The Cancer Care Talk Show has proved to be a crucial part of sharing verified information at a time when institutional care was not accessible due to the pandemic. So before we go ahead with the sessions of the day today, let's do a quick recap of all the work that we have done to raise cancer awareness through our cancer care shows and the cancer summits over the last 2 years.
विदेशों में कई जगहों पर जो कैंसर टिश्यू बैंक होते हैं, हमारे यहाँ भारत में कम है, तो हम ये कैंसर टिश्यू बैंक जगह जगह जहाँ कैंसर के इलाज होते हैं उनसे वो वहाँ पहुँचे.
We don't control the prices. You regulate the profiteering.
For every 3 patients that we diagnose, 2 succumb to cancer in our country.
Actually, there cannot be, any bigger concern as the cancer is posing today to us. Cancer harega, desh jeetega should also be a motto for us. Time again to focus on cancer.
I congratulate Integrated Health and Wellbeing Council for bringing diverse stakeholders and experts together to further boost cancer prevention and control activities in India.
In spite of the knowledge and information awareness, its real application remains doubtful.
Early detection is the hallmark to cure.
Access quality care is something that we really need to work on. Everyone knows that prevention is better than a cure. Prevention is also cheaper than cure. And so in countries like ours, we need to focus as much on prevention as on treatment itself.
Eat natural and organic, because pesticides and chemicals are going to harm our bodies, and they are leading causes of mutations. Second thing I would say, get enough sunlight, because sunlight is very, very important for setting our rhythm and also protecting against many diseases. Third thing I would say is that for fiber, start eating natural vegetables and fruits, which are at least 4 bowls every day.
I feel the next 10 years is the best period for India to leapfrog into the actual innovation space.
And we continue with our efforts to raise awareness about cancer in the third Cancer Summit that we are bringing to you virtually. Now, how can cancer be detected early in our country? What is the cost to patients, families, and the healthcare system of delayed diagnosis of cancer? In our first session of the Cancer Summit, we'll be discussing the role of timely diagnosis and the consequences of delayed health services. Please welcome a panel of experts who will discuss this topic. Please welcome Dr. Vineet Talwar, Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Mantri Bakre, Founder and CEO, OncoStem Diagnostics. Dr. Somashekar SP, Chairman and HOD Surgical Oncology, Manipal Hospital, Bangalore. Dr. Kishore Singh, Director, Professor, Radiation Oncology, Lok Nayak Hospital, New Delhi. And Dr. Harsh Mahajan, Founder and Chief Radiologist, Mahajan Imaging Center, New Delhi. And Ms. Neeti Lekha Chhabra, Founder and President, Yes to Life. A warm welcome to all of you. Thank you so much for joining us on this session. Very important to understand why we must catch cancer early. So while we don't want to create any fear of cancer, because cancer is curable if caught early, perhaps what really drills down in the minds of people is the cost associated, the cost of delayed diagnosis of cancer. Dr. Mahajan, let me start with you. For a very large section of our society in tier 2, tier 3 cities, even the diagnostic, to make a diagnosis, be it a biopsy, a scan, they're expensive. Healthcare, could have, and the cost of healthcare have a drastic consequence to their economic well-being. Sometimes they're fearful of even sinking in that small cost because they feel we are not going to get it. Why would we get this Western disease? So, do you think this is one of the reasons why, diagnosis is delayed?
Well, thank you very much for having me on this very illustrious panel. What you say is true to some extent, but I think it's more not that these tests or doctors' visits are expensive. In fact, India provides the cheapest healthcare destination in the world. And when I say that, I compare with Pakistan, Bangladesh, Sri Lanka, and Nepal, our immediate neighbors. We are even, at the quality that we give, and even when we compare with these countries, we are 20 to 25% cheaper than them. So India currently is the cheapest quality healthcare destination in the world. I think the problem lies, one, with affordability. It's just that even though this is so cheap, our people don't have the money to be able to go and get these tests done. If we were to compare with the West, then some of these, surgeries, treatments, procedures may be even 100 times more expensive. More expensive in the West.
Okay, expensive in the West, but cheaper in India.
Absolutely. The second, I think, is a lack of education, lack of knowledge about, despite all the drilling down that councils like yours do, the media does, doctors themselves try, still people are not aware of the fact that if there is some, and if we talk in the context of breast cancer, there is also something like a hesitancy, a taboo to even talk about these things. And so a lump which someone may feel, we see so many times that this lady will come after 6 months or a year when it actually becomes very, very large. So it's a combination of things. And I think the solution lies in education, of course, in providing healthcare facilities in tier 2, tier 3 towns, as well as in the rural areas, and somehow getting in a mechanism, whether through insurance, which may be mediated by the government, or private insurance, a co-pay kind of system, so that there is then at least the affordability part gets taken care of and the others can then be addressed.
All right. So Dr. Mahajan has raised two important points, that the cost of diagnosis and the stigma of the disease are, could be two factors, not the cost, but the affordability of the diagnostic test and the stigma associated with cancer could be perhaps the reason why we see some reluctance of getting cancer testing. I want to come to you, Niti. You're a cancer survivor and you also work with a lot of cancer patients. We've spoken about affordability, we've spoken about stigma. What about fear? Is there a fear amongst people that I may contract cancer, so I'm going to die, so I don't even want to test? Why get the bad news? Let's live in ignorance. Is this true?
Hi, thank you for having me over. And yes, I personally agree with this, that fear is also one of the reasons for late diagnosis. Somehow people go into denial, because that's the only way that they seem forward, that they don't have to get tested at that time only. While, of course, as we all know, that eventually the person will have to go to the doctor, and at that time it will be even more difficult to sustain life, to have a very good quality life for the future. But yes, a lot of people are very fearful. I know of patients who actually fainted in the doctor's office when they were being told that they were diagnosed with breast cancer. So that's the kind of fear that we have here in India. And one of the reasons behind the fear is also that in India, the mortality rate is very high. Now, whether it's because of, of course, it's because of late diagnosis that the mortality rate is high, but for the reasons for people going to the doctor in later stages are stigma, fear, lack of awareness, the cost that one may consider. And also I have seen a lot of cases wherein the women refuse to somehow take responsibility of their own health. There are other things that come in the forefront. Very recently, I got to know of somebody who had a lump in the breast. She knew that there was something wrong, did not tell her family members. Like, she's a mom, she has very, her kids are around 20s. And finally, when she was taken to the doctor was the time when blood started to ooze out of her breast, So that was the time when neither she nor the family could, sustain her not going to the doctor further, and the family got to know. But by the time she reached to the doctor, the cancer has now spread to a lot of other body parts. But she knew about it well in time. But so there are a lot of reasons that lead to late diagnosis here.
Okay, so we've listed affordability, fear, lack of awareness, and stigma. Dr. Somasekhar, it's a vicious cycle now. You're fearful because mortality rate is high. Mortality rate is high because you come late. So how do we tell people that come early and you will live, and cancer is not a death sentence?
Absolutely, Anisha. The problem in India with the cancer burden is twofold. Number one, our people come late. Yes, so that means there is a problem in education awareness and able to understand. There is a research from UK which says 80% of the symptoms which people notice as early cancer are never able to identify. Like, we have caution, CAUTION, any source, loss of weight, any cough you have to come. The first onset of any symptom is so non-specific, 80% of the healthy, educated public cannot identify. So in India, our cancers come late. This is one problem about education, awareness, screening. Second is, even after a diagnosis of cancer is made by anybody, primary healthcare, second tier city, PHC, primary doctor, not necessarily oncologist, then coming back to the final definitive treatment, there is a very long delay. How is it reflecting? India contributes less than 1/3 to the breast cancer, but 50% mortality to breast cancer. There is something wrong. We are not the leading cause of breast cancer, but leading contributor to death in the woman, which is very sad. This is called as, there is a gap in the care after diagnosing cancer. If you see the World WHO, the motto and the theme for this year is close the cancer gap. Means what? Even after I know today there is a cancer, By the time they reach the definitive curative treatment, there is a long delay. Delay from patient, delay from healthcare worker, lack of awareness, delay in availability of the diagnostic, even if they are available, not utilizing this. The cancer research UK showed, even in Western country UK, 46% of the patient come late. 50% of them come so late, they are not curable. So, we need to work in this WHO motto that close the cancer gap and end the cancer we know. So, these are both problems, we already have it. Symptoms are not known. People wait for symptoms. Screening is non-existent. Cancer is not notifiable disease in India. Tip of iceberg is the burden, what we bring in the cancer registry. Symptoms, even a doctor themselves cannot identify the symptom, 80% are non-specific. Worst is after diagnosis of cancer, by the time they come to a definitive free treatment in regional cancer center, long gap. Doctors are possible, nurses, healthcare workers. So, these two problems, we have to tell the people even after you're diagnosed. In UK, there is a rule. The moment you diagnose a cancer, within 4 weeks, you have to start the definitive. But in India, we don't have. So
yes, because the UK has an NHS and a very world-renowned healthcare system. Yes, robust system. Perhaps a comparison with India is really not
so
apples.
Imagine there, if we have this in India, average time is 3 months to 6 months. So what happens? There is loss of survival. We need to use more than one modality, surgery, chemo, radiation. Now imagine the cost. Already ours is a financially resource challenge setting with patients' healthcare. 3 modality, 4 modality required, cost, duration of treatment, and loss of organ. Breast cancer, they lose breast. Voice box, they lose an organ. So we call this an era of organ preservation protocol that is lost. Cost to family, healthcare, multimodal treatment, suboptimal result, and lose a cure. So we need to address both at education, cancer awareness, screening to pick up early, then close the cancer gap and give a cure so there is no delay at all the level and educate the people.
All right, so we will discuss how to fill this gap in cancer care a little later. I'm still trying to understand the cost it entails on patients, their families, on the healthcare system. Dr. Kishore, what would you like to say? What's the cost of late diagnosis in our country?
First of all, I would like to thank ISW for taking a very relevant topic. I start with the 2 phrases. Every day counts and delay is deadly. Cost to the patient, to the society, and to the system. So to the patient, stay will become longer moment the diagnosis is delayed. Treatment will be more complex, involves multimodality, so sequelae will be more. So patient will suffer more from both short-term and long-term sequelae. And since the stay is longer, so they have to spend more on the logistic and stay. To the system, higher the stage, longer the treatment means system will occupy for a longer period. So lesser number of patients can be taken up for the treatment. Besides this, we are having a lot of shortage of teletherapy machine because I am radiation oncologist, so I will talk about that. As per the world data, we need 1,350 LINAC, 1 LINAC per million of population. Right now, we have only 545 LINAC. So we are short of 800 LINAC machines. To overcome this, should I start now?
Yes, sir. Please go ahead.
Okay. To overcome this, we have to work on many fronts. Right now, out of 541 medical colleges, only 87 are providing radiation oncology facility. As per Government of India, each district have to have a medical college. So out of 741 districts, 463 are yet to have a medical college. So if we have radiation oncology or oncology department in each of the medical college, we can add 917 oncology department. That will massively improve cancer diagnosis as well as cancer care. But it involves a lot of expenditure. Machines are costly and availability of expertise, which is very short right now.
Right. Dr. Talwar, we've heard number of issues that lead to late diagnosis: fear, stigma, the affordability of diagnostic tests. Other doctors have highlighted the cost of late diagnosis, and the lack of infrastructure is also being cited on why there is this care gap. Who's going to fill this? Because there is a need in our country. There are millions, like Dr. Somashikar said, it's just the tip of the iceberg. The numbers you see is just the tip of the iceberg. There is a large unmet need for the equipment to be there, for diagnosis to happen, for treatment to happen. Is it only up to the government to do this? Because even the private industry does cancer treatment very successfully. They make the profit, they give the solution. So who does the onus lie on?
Well, thank you, Anisha, for the question. And, we always talk about accessibility and affordability. The key point here, what I personally feel, is the feasibility. Now, when you compare India, you compare with UK. UK has a population of which is half of Uttar Pradesh. So you see the quantum, 130 or 140 crores, and your budget is limited. That is point number one. Point number two is that, as far as the West is concerned, you don't have the psychological overtones, you don't have the emotional overtones, you don't have the demands of tradition and the dictates of religion. And, they top it up, the lay beliefs which are there, because all these things coupled with the good education, they create a barrier. Because whenever a person has, a lump or something which is obvious in the body, he or she goes mostly to a faith healer, hoping that cancer, it is not me, it is with somebody else. That leads to delay. Financial barriers are there. You see, insurance cover in India is a paltry 7 to 10%. And we compare ourselves with US and UK, where insurance cover is almost universal. So these barriers are there. Education, of course, is there. WHO guidelines of 2020 say that you create the awareness of symptoms. If the problem is there, you have a rapid clinico-pathological test and then refer to a specialist. You tell me in India, how is it possible? So the way to go forward is that we should have a robust population-based cancer registry system, which at this time is not up to the mark, in which we can isolate areas which have a high risk preponderance for a certain kind of cancer. And then, allocation of the resources can be accordingly, because you can't allocate resources to each and every state in a simplified manner. So it has to be a protracted way by which all these things have to go. And lastly, there is a disconnect, as the other panelists have already told, between the discovery and the practical connotations.
Okay.
And that disconnect is, of course, the resources, the health education and everything. Cost per se has to be a corporate social initiative, has to be a government effort, and has to be a private effort. But then how to juggle around with all these three, because at the end of the day, the resources are limited. The allocation of resources has to be according to the specific high risk areas or low risk areas, where you can step up the screening programs or reduce the screening programs. That leads to a cost cut, and that can be allocated somewhere else. So I think it is not a very simple situation as far as India is concerned, because the clinical connect, the psychological connect, the religious connect, and the financial connect, you have 5-6 pillars which you have to overcome when you take a decision making as far as the treatment and the screening and the planning is concerned.
All right. The cultural and social conditioning is something that will take time. But Dr. Talwar has pointed out the feasibility of having well-structured and all-over infrastructure for cancer diagnosis and treatment. Also not something that is very easy to implement. So Dr. Marji, what is the option then? Should we just say, oh, we don't have the resources, we're just going to have to deal with it? Because COVID has shown us that we can fight back. We can use technology innovation to find a solution. Can we have technology innovation helping us here with early cancer diagnosis as well?
Yeah, absolutely. First of all, Anisha, thanks for having me on the panel. It is absolutely a pleasure to be here, and really appreciate the work you guys are doing to create awareness. So coming to the question, yes, I think we absolutely have to, we must make efforts to really create awareness, whether, I mean, everybody needs to pitch in here, not just the government, but not just the central government, but the state government, and every resource we have. I think we have to put in effort, whether it is hospitals giving out, and there are many efforts are being done. They have these buses where they screen for breast cancer, cervical cancer, etc. NGOs, industry also can pitch in to really contribute to this, whether it is pharma or diagnostics. I mean, they each of us should really do create awareness efforts to really make sure patients, people in general, are aware of what are the issues faced by, which can be solved when you are diagnosed earlier than later. And startups can absolutely pitch in by contributing really good technologies for easier detection on site, like at the patient's residence. They don't necessarily have to, because in our country also the issue is patients are in rural small towns and they need to travel a long distance to come and get screened. So if the technologies are point of care, they can be taken to the patient, and patient can be screened for different malignancies, whether it's oral, cervical, breast, or any. It will really help to diagnose early. And this is where we need to really put in all the effort to really come up with really smart, innovative, and reliable technologies which will help point of care diagnosis, which will help to screen at the point of patient.
Right. Dr. Mahajan, are you aware of any innovation or research being done so that we find our own ways to screen early for cancer? Because I spoke to a representative of a government-owned company based in Hyderabad. They tied up with Uber. Uber would send you, you would have to download an app. You would call for an Uber. They would test whether you required an oxygen cylinder during COVID. If you did, you'll be delivered a cylinder right at your doorstep. But they had the innovation to, check for the oxygen levels and flowmetry, etc. They had those things. And I was told that there's more work underway in Internet of Things, in bringing up sensors so that healthcare becomes more decentralized. Could this kind of research be replicated for early cancer diagnosis?
I think not only will it be necessary, it is inevitable, because as Dr. Alwar pointed out, with 1.35 billion people and limited infrastructure, limited number of skilled doctors, nurses, we will have to think of innovative solutions. There is no other way. And let me, give a few examples. And you gave the example of this COVID pandemic. And here we've seen that even seriously sick patients were treated at home through telemedicine because there were no hospital beds available. So someone with an oxygen saturation of 80, who should have been in ICU, was treated at home, and many of them survived. And similar would be the case both in diagnosis, wearable devices, and young startups are doing a lot of work. We hear of so many startups in the artificial intelligence space where they may be able to provide solutions based on a chest X-ray or a chest CT. Automatically, artificial intelligence algorithms are able to pick up abnormality and then also quite accurately be able to say that could it be malignant or is it benign. We've done some work in this space ourselves, and these are still early years, but I'm sure a lot of the screening part, a lot of the diagnostic part would be helped by artificial intelligence algorithms. Now, another specific example I want to give you, and this is I'm with a group of METI, that's the Ministry of Electronics and Information Technology, which helps startups. It also has, labs. In Thrissur, there is the CMET lab, which is actually in the last 3 years developed a bra wearing which a lady can actually pick up early breast cancer. It is a screening device. It has thermal sensors within. And we know that in the skin overlying a breast cancer, that area becomes hotter than the area around. This is the thing that has been made use of, and this bra has been indigenously developed. It has multiple sensors. A lady needs to wear it for 10 minutes, and this is something which can be actually taken to rural areas where all it requires is a computer along with, and in 10 minutes it can actually screen out those who may be at higher risk, and then they can go for a mammogram and whatever else may be necessary. This has already been transferred. The technology from the lab has been transferred to the industry, and very soon we hope that this would be available not only in our country but also globally. So there is no doubt that remote access, both for education as well as for examination, Dr. Talwar sitting here or Dr. Somashekar sitting in his office may be able to provide, facilities in far-flung areas, be it the PHCs or the CHCs. So actually, in our country, with the population, we will have to think of innovative solutions. And I think this digital thrust that is there in this country will go a long way in facilitating early diagnosis, proper treatment, having only those who need to come to the cities for specialist treatment needing to come, and not all and sundry. So, but this is not going to happen overnight. There's a lot that needs to be done, but this is the way that this country will be able to provide universal health care and early diagnosis, especially for cancer, even for coronary artery disease, hypertension, renal disease, to the billions that we have.
All right. Dr. Manjari, would you like to add to this? Because a lot has been said about liquid biopsies, how a blood test may help in detecting your risk of cancer, etc. Now, we are still waiting for all this to become mainstream, because there is a significant procedure to ensure that specificity and sensitivity is high for these tests, because we don't want to alarm people and we don't have false positives. So then do we have to keep waiting till we get the go-ahead from international agencies? Should we bring in these pilots? How do we go about this?
So yeah, I mean, we today definitely need more non-invasive technologies or less invasive technologies. With every time there is a suspicion, if the patient can, instead of going for a PET CT, if he or she can look at the possibility of having a tumor by doing a liquid biopsy, absolutely, why not? That is really the need of the hour. We need to really make those technologies absolutely reliable. But that does not mean that we use less reliable or non-compliant or less compliant technologies. They have to be accurate. They need to be assessed by the authorities. They can be within India as well. I mean, they don't need to be all international. So we need to have those systematic guidelines to approve new technologies in India. We don't always have to rely on CE mark and ISO certification or FDA approvals from the outside of country. And I think we are making steps in that direction. I think CDSCO has given out regulations on various medical devices, lab developed tests, and there are many startups in this space. So I would really, short answer is yes, we need these kind of non-invasive, less invasive, simple methods, but they have to be accurate. I totally agree with you. We cannot increase anxiety in the patient by having less accurate tests in the market.
Right. Nidhi, you work with breast cancer patients, and Dr. Harsh Mahajan has spoken about this bra with a sensor, where we'll try to pick up breast cancer early. This is very innovative and very new. Do you think people will be forthcoming to adopt these kind of newer ways to diagnose cancer? Because of course there is a cost involved with traditional diagnosis and a fear also. But will they be willing to try something absolutely new?
So, I have actually been in discussion with a lot of doctors because, like everyone here said, that there are a lot of such modalities by startups which are coming up. And I have been in discussion with a lot of doctors because for very long, I have been wanting to do something in terms of mass screenings. And we know that here in India, running a mammography or an ultrasound on everyone is not possible. But like Dr. Harsh said, that we are still in early years. So till the time that we do not get these authorizations done, we really cannot start to do these on people as such. But with everyone whom I've spoken to, I think people will be ready to adopt these technologies, and we have to reach out to people with such technologies, once these are authorized. Because even though people who may be able to do ultrasound and mammography today do not go for their regular screenings. So it's more to do with us reaching out to them, giving them this information, and also giving them this chance and this alternative that there is also a way that you can be doing this sitting in the comfort of your home, whether it is urban or it is rural, because both urban and rural don't go to get their screenings done for different reasons. So if we, like as an NGO also, I know once we get to go ahead that all of these have high levels of accuracy and these can be done, it is not just like one sector, but we will reach out to both urban and rural through these technologies. And I am sure that we will be able to have more number of early diagnoses through these, because the cost is less, yes. And second, like I said, if you are able to reach out to them at their homes, it is a much easier way to do these screenings instead of always telling people go and get yourself screened.
Okay. Dr. Talwar, you spoke about the feasibility of ideas and the lack of infrastructure. And like Dr. Shomasekar pointed out, we have to fill the gap in the care. What are your ideas to be able to do this in a country which is so large as ours, so diverse as ours, and has so many challenges?
So this I can break up into 3 points. One is the screening. Screening in India, as cancer is not a notifiable disease, it is elective, meaning thereby if I want to get screened, I go and get myself screened. It is not the other way around. Second thing is what the government is doing. Well, you have the National Cancer Registry Program. Now, what National Cancer Registry Program has done is it has tied up with the population-based cancer registries. These are certain centers throughout the country. And they in turn have tied up with National Center for Disease Information and Research. Now, this is the IT arm of the National Cancer Registry Program. What it does is, of course, it collates the data, but along with that, it has a lot of data for the patient information and patient treatment. So I think the way forward would be, ultimately, it will boil down to the finances, the allocation of resources. If you don't have the resources, nothing can be done. Everything is in the air. So the allocation of the resources will be based on what the data informatics tell the National Cancer Registry Program through the population cancer registries. So you have the data, you have the patient information, and then you can have the patient connect. Now, the new thing which has come is COVID. COVID is the new kid on the block. Now, COVID, it has been a disaster for all of us, but the flip side is that it has pushed all of us towards IT. You cannot imagine 3 years back, a person in the hinterland who would, attend his or her classes, whether it's a child or whether it's a college-going student, through a mobile phone or something. So the aftermath is that you were forced to do all these IT things in the armamentarium so that you could connect or maintain connect with the other people in the country. So this has, led to a big quantum leap, and now we can use these and the data informatics, which is tied up with the National Cancer Registry Program, to augment this thing, because the most important thing here is finances and connect. Now you have the connect, and you have the registry program in which it can allocate finances according to the areas which need more thrust or less thrust. So I think this can be taken as a pivot to go forward and provide affordable and good healthcare. Healthcare in India is free, but then free means what we are doing at this point of time, we are giving it to everybody across the board. So if you select and you tailor it according to the state or according to the region which is a high risk, probably that will get the best benefit.
Okay, so these are an overarching view from the efforts that need to come from the regulatory and the government side. Dr. Kishore Singh, could you also talk about what could be the ideas to bridge this gap in care? And we've spoken a lot about cancers that are screenable, say a lung cancer or a breast cancer. They are screenable. Amongst at least those who are high risk, you can have protocols. What about those cancers which are not screenable? How do we detect them early?
Actually, cancer is producing very non-specific symptoms, which are similar to other illness. So only thing is making them aware of the thing. That if symptom persists for 15 days or month, they should seek a medical attention immediately. Other thing is making aware of the physician or surgeon who should think of cancer whenever examining the patient. The drawback here is the training of our MBBS is not having oncology or radiation oncology as essential subject. It is an optional subject. So they are not sensitized enough relating to cancer diagnosis or referral or care. So this has to be bring to the mainstream by including oncology or radiation oncology as a subject in the MBBS. Other thing is like AIDS or other programs, this should come into the media frequently, because cancer is going to be a big problem in future. As we are aging, our population is increasing, it's going to be a leading killer. Already it is among top 3 killer, but it will in future going to be second most common killer. So this has to be bring to the notice of general public by bringing it in the media more frequently, and events like you are organizing to make it increase in the awareness.
Right. So we are running, all these shows, and we're getting all the experts, so that the awareness does increase. But perhaps what will work is to have a good campaign with influencers and real life examples, because they really do inspire. And we need something at a scale which the government can also perhaps put its weight behind, so that it resonates with people. We've seen what's happened with Beti Bachao, Beti Padhao. So we need these. It has to be front and center, like Dr. Talwar pointed out. The government has not notified this disease, so it's all optional. But now we really need to step on it and talk about this very urgently. Dr. Somasekhar, in the care gap, will insurance help, or will it delay treatment even further?
Absolutely, because cancer treatment is very expensive, even in early treatment. One is accessibility, affordability. Most of the people shy away because it is more than one entire year of entire families earning for one cancer treatment, and then it's a financial toxicity which knocks off the family, and you may come out survival, but then it's very tough. I totally agree with you, but the way current insurance scheme is existing, it's not going to help. Because we need micromanagement. They are at macromanagement, and nobody has an assets to pledge and take. So there has to be a micromanagement of the finances. The way to work in India is we have more than 1,400 types of cancer. We cannot formulate for a country like us financial allotment. Traditionally in India, the whole concentration of 5-year plans, health, treatment, budget allocation is infective disease, tuberculosis, polio, vaccine. Cancer is last. So if we identify top 5 cancer, which are number 1 in India among women and men, and leading cause of death, and formulate a guideline, like, in women, ultimately breast cancer, gynec cancer, 70% of cancer, 80% of death. In men, as of today, as per the cancer registry, oral cancer, lung cancer. Take these 4 cancers, formulate a package which is incorporated into government schemes. Now, we know in India, state governments, Ayushman Bharat, lot of them are there. Identify, this is an era of not maximum tolerable treatment. Forget the West. What is minimum effective treatment for these 4 Indian cancer? Completion of treatment is most important. Incentivize the hospital, doctor, healthcare worker scheme of completion of treatment for these 4 cancer, and develop make in India, Indian solution for Indian problems and made in India with the startups and technology. Like I'll tell you an example. In COVID, without a mobile OTP, no RT-PCR possible. Without that, remdesivir cannot be given. Without the tocilizumab not given. People thought, oh, India is so backward. Everybody got a OTP. Everybody got their RT-PCR registered. Everybody got all the drugs, which means everybody is able to do technology. So link it to our Aadhaar and this. Develop Indian solution for Indian problem. Forget maximum tolerable treatment. Find the minimum effective treatment for Indian cancer. Formulate for these 4 cancer. 75% of cancer in India are covered. 80% mortality will come down. And use technology and make package, and at government level and national level, micro-financing management to complete this treatment, not just initiation, is the go. It is easily doable. India is the place for largest affordable tech and largest amount of local drugs are made here. Expensive drugs by law, by a Supreme Court's law and government, and through Ayushman Bharat, we have generic, which is 1/10. So for cancer, do it, find Indian solution. Already, like Dr. Manjari's company has developed a Can Assist, which is an Indian solution at 1/10 the cost, which is validated in Indian patients. We have run a trial where we have a point care device which can be taken to rural to pick up breast cancer. We have developed a ICG, which is less than 800 rupees to identify sentinel node in women. So find these solutions and let West look to us, and we will concentrate on these 4 cancer, 2 in men, 2 in women. Standardize it, minimum effective treatment, Indian solution for Indian problem. We take a large step towards the cancer treatment in India.
Right. So these are also very good suggestions and great ideas. We're coming towards a close of the show, and I'm going to take concluding remarks from all of you. Dr. Talwar, are you aware if the government is aware or working towards, prioritizing at least these 4 cancers or some of the cancers that are affecting a large proportion of our population, because cancer care is covered in Ayushman Bharat. Basic chemotherapy is covered in Ayushman Bharat, but like Dr. Shumajika said, the entire treatment has to be completed. Plus, Ayushman Bharat is covering only the lowest people in the pyramid. What about the middle class? Because even for the middle class, completing cancer care treatment they'll need to break the bank. It is a big cost. So are you aware of any action that the government is planning to take? And what are the steps you think the private sector can take here?
Well, I'll take a very holistic view of this. Being a cancer physician, whenever I come across a patient, cancer treatment is unlike the other treatments. Unlike a chap who has a cardiac arrest, a cardiac attack, or a stroke. When you treat a cancer patient, you're treating the whole family, because sometimes the cancer patient may be the only family provider, and it hits like a bolt from the blue. On one side, you are staring at the cancer patient and his treatment, and on the other side, the breadwinner is gone. And that happens in all these situations, especially in the middle class and the lower income group. So, of course, the government is pitching in, and you have these states where you have about, I think, 50,000 capping for treatment, and the drugs are available at subsidized rates. Even here in Delhi, it is so. You can go to any government hospital and get treatment at a highly subsidized cost. So I think there is no dearth of talent. There is no dearth of the resources. Only thing is how you allocate and how you proceed. That is the mantra. Simple thing like a guy who got through IAS, who was working as a coolie, he used to connect his phone from the free Wi-Fi which was there on the railway station. If that guy can do, why can't we? So you have to do some out of the box thinking to get along and make that connect.
And you also need a will. You also need a will to
Definitely,
succeed.
that is sacrosanct. Yes.
Right. Dr. Mahajan, what would you like to say in your concluding remarks? Are you aware of any action that the government may be thinking of taking to work on these 4-5 cancers that are affecting a large majority of our population?
At the outset, I'd like to echo what Dr. Talwar has said, and also what Dr. Somashekar said. Indian problem, Indian solution. And we have leapfrogged. You've seen we leapfrogged. We didn't have telephones, landline phones, and how we have leapfrogged with the cellular telephony. Similarly, I think using medtech, using the talent in our country that we have to look at indigenous solutions. And I think it's a great suggestion that Dr. Somashekar has done. Just pick up 4. And when you ask whether the government is worried about this, the government surely is worried. The government is aware and wanting to do something about this. And I think this focus on maybe a limited number of cancers for maximum output would be a great way forward.
All right. Niti, what would you like to say in your concluding remarks? How important are support groups? How important are campaigns? And how important are survivor stories?
So absolutely. I mean, and all of these survival stories, see, whenever I take an awareness session, I always start by sharing my experience of having been through cancer myself. And that is where people start to relate to what I'm saying, and they start to think that, all right, if it can happen to her, it can happen to us as well. So having it is so important that more and more people should come out and start to share their stories. And I have also started to work on that these influencers should not only be from urban population but equally so from rural population, because it's a lot of stigma in rural population also. And if people come out in front and talk about that they've been through this, I think it would really increase the awareness. I also want to take 2 minutes to share something here, since we've been talking about that who should be taking up the burden and, helping out, doing all the treatments and everything. I personally feel that it cannot be in India, considering the population and the cancer burden, be the responsibility of any one sector.
Stakeholder.
So government, public, private, NGOs, charitable trusts, I think everyone has to hand holds together. And even then, nobody can work exactly in isolation here. So we at Yes to Life have recently collaborated with, Gurugram Health Department, and we're starting a breast cancer screening center here, wherein we would help these, women from lower income groups, not just to spread awareness, but holding their hands throughout their screenings till the time the treatment gets over. Because more often than not, what happens is that their screening's done and then they're left on their own to fetch for themselves. And I don't think that specifically when we're talking about people who can't afford the treatment, you can leave them just telling them that you're diagnosed with cancer. So this is a new initiative that we're starting, and I really hope to collaborate to speak to many of the panelists who we have today with Dr. Harsh Mahajan also, because we need to actually, we would need support to take this forward and be able to help as many people as possible.
Definitely. Empathy is very, very important if you need to fight cancer, because just catching it early is not the answer. To treat the patient as a human being, to address their worries is equally important in their fight against cancer, and they're coming on top, because if they are mentally strong and emotionally secure, they will feel more confident about fighting this disease as well. Dr. Manjri, what would you like to say about innovations underway, about how to create awareness, and when should we start talking about all of this?
Sure. So I think we all agree that innovations are really required to really tackle cancer in a big country like ours. What is also important is using these innovative mechanisms in a day-to-day use. So all the various innovative ideas that startups come up with and make products, they need to be integrated in our systems. So while government has made all this NDHM and really open system, etc., they need to really incorporate each of these technologies into the workflow of hospitals to really make sure that they are easily made available to people, whether they are point of care or they are in hospital or they are sourced out in different centers. They need to be integrated, and so the startups also can see a way forward for their technologies, and they would be enthused to make more. Because where the startups, innovative startups face the issue is, yeah, I have made a product, but then what
how do I
next?
take it to the market?
Exactly. How do I, because they have limited resources to go to market. So if government can help at this point in really make, because the point is to really make sure that it is used by every eligible person, patient, that he or she needs. And so if this can be made use, it can be put into the government system for in a systematic workflow process, it would really help start the new innovations reach the public.
And why just the government? Even corporates who see a business case, they should tie up with startups. And I'm sure, and I hope that platforms come where this connect happens between innovators and those who will bring this innovation to scale and ensure the adoption at scale in our country. Dr. Kishore Singh, what would you like to say in your concluding remarks? We want to catch cancer early, but perhaps it's not just enough to talk to prospective patients. Perhaps you should also talk to physicians who sometimes say, "Arey khansi hai to TB hoga, pet mein dard hai to hajmola le lo." We need to have this awareness amongst the medical fraternity as well, to be alert for the possibility of cancer in some cancers which may not be that easily screenable.
Government of India has envisaged a program under National Program for Prevention and Control of Cancer, Diabetes, Cardiac and Stroke. They plan to screen all persons above 30 years for oral, cervical and breast cancer. Modules have been prepared and they are planning to launch it through Wellness Center. Besides this, machines are being developed with indigenous technology through AARB. Panacea is developing it. Basic linear accelerator has been developed and now they are going for the advanced version. And regarding awareness is concerned, we have to incorporate in education itself, and then when they are updating through the talk show or webinar or seminars to make them aware of this problem, because it is going 3% cancer is increasing every year. And besides this, tobacco epidemic will going to produce more and more cancers in the future.
Dr. Kishore, very quickly, when do you think is a good age to start talking about this, or a good time to start talking? Who should we talk about cancer? Maybe young girls, maybe students in college. When do we do all this?
We should start from the school itself, because they are the most sensitive people where we can sow the seeds for their future awareness.
Okay. Dr. Somasekhar, what would you like to say in your concluding remarks? How to catch cancer early and how to make people aware the cost of late diagnosis is too high?
Absolutely. If you follow the motto, I can, we can, I can, I will, then I close the cancer gap. If we follow this particular motto in India, and then try to tell the people screening is more important than waiting for symptoms. 80% you cannot identify. The incentive of that is you will identify cancer very early. You don't lose an organ. You may get away with one single modality, quickly go back to your normal work, and then, very low and better outcome for you and your family. And the best way to celebrate your birthday is to, on that day, to make aware within your family and neighboring that there is once a year, few hundred rupees of cancer screening package, which will protect you against 4 major cancer causing 80% of death, is something which is very important. And not always to crib that government should do. This is our health. Somebody can help you. Unless we help ourselves, even God cannot help us. So we must understand that we're a part of it. We have a responsibility of ourselves. Take help from government and NGO, everybody, but we are the major person. Ultimately we are going to suffer. So we should stop looking at somebody else, look in self, and then take help whichever comes from everybody. Once you win over the cancer and become a cancer graduate, not a cancer survivor, take that God has given you second life. Take that motto of cancer survivorship group, spreading the education. About 1 week of your life in a year, use it to spread within your mohalla, in your area, and that's how we change the whole society, and we share that responsibility.
All right. Great ideas coming from all our experts joining us in this panel. I hope that there'll be greater collaboration between all of you to increase awareness, to ensure that innovations reach everyone. And as a country, we come on top to fight cancer better in the years ahead. Thank you all for joining us. Thank you, Dr. Somashekar, Dr. Manjari, Dr. Vishwa Singh, Dr. Talwar, Dr. Mahajan.
Thank you.
Neeti, thank you all for joining us and sharing your thoughts, your views, your wisdom with all of us.
Thank you very much. Anisha, you are such a good host. You have become a doctor now, you know. Even though we are participating in between the ideas you give.
Thank you so much, Dr. Somashekar. With that, we will wrap up this session, but there's so much more coming up for you during the day in the Cancer Summit. I will hand it over to Ms. Urvashi Prasad, the Director, DMEO, Niti Aayog, who is going to talk about universal health coverage, funding sources for cancer care, and some very important issues to be discussed here. It's over to you, Ms. Prasad.
Thank you. Thank you so much, Anisha. And it's a pleasure to here again discussing this very, very important topic. So I welcome everyone to this panel discussion, which will focus on funding sources for cancer care. I will just set out 2 or 3 key issues from a policy perspective at the outset before I go over to the panel, and we have a fantastic panel joining us today. So I think, you know, as we're talking about funding sources, I think it's very clear that it's one of the very important dimensions of universal health coverage. But it is ultimately obviously linked to the actual delivery of services. We see in many cases that, you know, people might am I audible? I just want to check. Can everyone hear me? Okay, yeah. So, yeah, so I just wanted to sort of set out 2 or 3 issues at the beginning before we start our discussion. So, yeah, so I think in terms of funding, you know, in the context of universal health coverage, obviously the access to services, the quality of services are also very important and linked dimensions. I think from a policy point of view, we really need to do so much more when we talk about providing access to care, good quality care, much closer to people. When we talk of our smaller cities, towns, rural areas, remote areas. So I think that's obviously a very big and linked challenge. On the funding itself, there's several questions that you know, come up in terms of the quantum of funding that is provided. For instance, in some of the insurance schemes that we have, you know, how extensively are they actually covering, you know, the costs of cancer, because we know it's such a complex disease. Often the treatment is very complex as well. So is it truly covering, you know, the full cost of the diagnosis and the treatment? So I think that's another very important question for us, and an area where a lot of work is needed. Also the fact that a lot of the cancer cases in the country are still getting diagnosed at relatively advanced stages. And obviously this has implications for the funding as well, because, you know, if you catch something early, obviously you have a better chance of, you know, perhaps treating it also in a much more quicker and also perhaps more cost-effective manner, as opposed to a cancer which, you know, comes up at stage 3 or stage 4. So I think we have a lot of these questions, and it's obviously a major issue on the policy side. Some steps have been taken, and I think some of the previous panelists in the earlier session were also alluding to some of them, in terms of health and wellness centers, in terms of you know, Ayushman Bharat, in terms of the digital health mission, and what does that mean? You know, how that can possibly help. So I think there's a lot of that. But there's also a lot of challenges. So I think that's what we want to discuss on this panel today. I would like to just quickly introduce our, as I said, we have a very eminent panel joining us today. We have Dr. Lalit Kumar, who's a professor and head Department of Medical Oncology at AIMS. I believe Dr. Kumar is perhaps facing some issues right now with the technology. So we'll hopefully have him with us very soon. Mr. Vibhav Garg, who's the Director, Health Economics and Government Affairs at the India Hub and ASEAN and Boston Scientific, and Mr. Peter, who's the co-founder and CEO at Arogya Finance. So I will begin, in the interest of time. Perhaps we'll. I just wanted to check, Dr. Kumar, are you able to hear me now? I'm not sure he is. Maybe we will begin, and hopefully he'll be with us soon. So Mr. Garg, if I can begin with you, if that's all right. So I'll just begin with a sort of broader question. I just tried to put out some context at the start of this panel. What do you believe in terms of the progress we have made when we're talking of financing and cancer care? At least when I think of it, it's everything, from the actual screening, diagnostics, treatment. So what are the areas where you feel we've actually made progress, and what, according to you, are some of the big challenges that really remain ahead of us?
Hello, can you listen to me now?
Yes, we can, Dr. Kumar. I hope you can hear us.
Yes, please carry on.
Yeah, Mr. Garg, over to you.
Thank you, Urvashi. Truly appreciate, and I first of all congratulate IHW Council to organize this summit on the occasion of World Cancer Day tomorrow. I think very timely discussion that we are having. Not just for World Cancer Day, but I think cancer is becoming or has become a challenge for the entire globe, not just for India. Particularly, I will wear my health economist cap when I'll be sort of responding to a few questions here, Urvashi, today. And if I see from a health economics perspective, I think this is one disease where health economics models right from prevention to diagnostics to therapeutics to palliative just go upside down, because you are not able to really manage the cost of the treatment right from when the patient is diagnosed to the patient sort of going through the care. We are finding it very, very difficult because modality changes, treatment protocol changes as the new technology is coming up, and Dr. Lilith will talk about it more. But I think, again, to particularly respond to your question, I would say we have come a long way as a country. From a cancer treatment perspective, there have been tertiary care centers, there have been state cancer institutes, there have been, I think from a diagnostic perspective, we have multiple installation of PET CTs across the country. We have many number of Linux in the country now for radiotherapy and so on and so forth. So I think from a very initial remark perspective, Urvashi, I would say we have come a long way as a country, not only for treatment but also from a diagnosis perspective. And I think in the previous panel, someone is talking about NPCDCS as a scheme, and I think the scheme has been widely implemented in most of the states, rather all the states. I think it needs a little bit overview now in terms of cancer screening, because I think that is lacking somewhere. Cardiac screening is happening very, very fast. Diabetic screening is happening very, very fast. Hypertension screening is happening very, very fast. But cancer screening, somehow, maybe because of the lack of resources at a district hospital level, where the screening is a long way. And as we all know, if we are able to diagnose a patient much early in the cancer stages, the burden on the overall system would be much lower. And I think that should be the focus for the funding that we are talking about, and we'll discuss more about it as we go along. Thank you for your question.
Thank you so much. I believe we have Dr. Kumar with us now. I hope you can I don't see
Yeah,
him on.
actually, yeah, no, I'm here. I'm just trying to connect actually. Now, I think the major issue which we face is basically the advanced disease, right? Where the major expenditure takes place. So, as rightly said by Dr. Garg just now, that if we can find some method to get these people in the early stage, this will reduce so by doing your screening, by raising awareness, and if they can come in the early stage, like stage 1 or 2, when your results are kind of more than 80% kind of long-term outcome, then and the expenditure on the treatment, both diagnostic is minimal, your treatment expenditure is minimal, and the long-term outcome is better. So that becomes like your major kind of focus, that how we can do that. So I think that's what I would probably say, that so that has to be the major emphasis in addition to many other issues. And if we talk on advanced disease, like, so we generally, like, you have like the out of pocket expenditure, since the facilities for treatment, for cancer treatment, is still limited to the big metros or major cities. So even though there have been now efforts, the government level, which are really happening, that to improve the facility now in this Ayushman Bharat scheme, the amount of funding which they are providing to all the centers in I mean, not only the big metros, but even the smaller places. So like whosoever is qualifies and they have this for the people, and so from that you can provide the 5 lakhs rupees for the per family, and especially in the secondary and tertiary care center. So the major drawbacks would be that if we can bring the cancer approach to the cancer centers within 100 miles or so people can reach in time there. So that is, I think, one of the thing. And the other thing would be so the providing the and the one of the other thing which we face, like in place when we work in All India Institute here, the people do not have a place to stay actually. So that becomes another source of expenditure for them. So like if we can find some method that they can find a place to stay when they have to stay long, because the cancer treatment is very long treatment, 4 months, 6 months, something like that. And then repeatedly they have to come for follow-up. So even if you treat somebody, but then if you lose them in the during the follow-up, so then your half of the battle has been gone. So, so these are some of the points I would say, which government has made, like through the Ayushman scheme and some of those things, which I think we had to probably consider. Thank you.
Thank you, Dr. Kumar. So I have some follow-up questions for you, but I'll come back to you once we hear from Mr. Peter. Mr. Peter, would request you to share your thoughts on this, and also if you can talk about any innovative sort of financing or funding approaches that you've come across, which also perhaps involve other types of stakeholders, because of course we're talking of the government, but there is, in something like cancer, there is obviously a need to have many more stakeholders, and there are many more stakeholders, whether it's the private sector, whether it's civil society, others. So if you've seen any sort of innovative approaches to addressing this funding issue, if you can touch upon that as well, that will also be great. Thank you.
Thank you, Vashi. Yeah, thank you so much. Yes, I agree. Doctor was mentioning about the Ayushman and the success that Ayushman has made to the, I would say, at the bottom of the pyramid. And today, the Ayushman Bharat has become aspirational for the middle class, because often the middle class do not have 5 lakh insurance. The poor has it now. So that has thrown up much larger challenges, according to me. So how does one address these challenges, and how do we ensure that the middle class who are, and the sad part of the middle class is one healthcare shock like a cancer in a family is good enough for the family to go back into poverty. Something that they climbed out for with years of effort can be lost with just one medical shock. Yeah, so that's it's a very difficult space and a very difficult situation. So I think one of the ways in which it is people are trying to address, including my organization, Arogya Finance, is how do we make finance available or access available to the middle class, including the lower middle class. Now, traditional banking channels find it very difficult because here is a patient who may be in an advanced stage of cancer, no idea whether they will survive, etc. And how do I go ahead and finance such patients, even if they have the ability to pay that over a period of time? So luckily, now for the patients, there are methodologies that have been developed where we are able to take into account the overall family's capabilities and create payment options for them, the easy pay options that have been created. Now, if you combine them with the 2 or 3 different things that the private sector is bringing to the table in terms of the patient assistance programs. So when you talk about finance, I would rather treat it as affordability or an access issue rather than a financing issue, because it has to be a combination. So you make access possible, which means you bring down the cost through patient assistance programs. You bring down the cost of borrowing through interest subventions, and using all of that. And if you are also able to bring in methodologies which will allow organizations to lend to people who are traditionally not considered good credit risk. If you are able to do all of these together, then many of these families will be able to get support. So I think today more and more organizations are able to do this, bringing together the patient assistance program, the subvention scheme, the ability to lend to people who do not have a credit history and things like that, and then make finance available. Now, the other obvious option is to increase the insurance, but the sad reality is known that many families don't have insurance, and even when they have it, the amounts are not good enough to cover a significant part of such expenses. So now, if the insurance is inadequate, then come out with a methodology to fund the remaining. So what is not covered under insurance, and what is not covered under insurance could be for 2-3 reasons. One may be the amount itself. Second, it could be deductibles which are not permitted under the insurance scheme. It could also be such care which unless there is a hospitalization involved, often insurance doesn't pay. So therefore, how do you deal with that? So that could be also part of those amounts that could be lent to these people so that they can pay it over a period of time. So there are and in many hospitals you don't have cashless insurance. So this becomes another challenge. Okay, I have the insurance, I know that I will get the money, but I don't have the money to pay today, and the insurance is not paying for it today. Now, how do I create? How do I pay and then maybe manage that situation until I get that money from insurance? So create bridge finance options. So these are some of the things that people are now able to do. So that is certainly increasing access to a significant number of patients. Then another area I think where some work is happening is okay, now here is a therapy which is considered very good. You know that it will work, or there's a very good chance that it will work, but it's so expensive. And now and unless I am even sure about whether it is going to work, how do I get into that program? So now if we are able to create an option whereby the payment is linked with performance in some manner. For example, I get into a program, pay for let's say 1 or 2 cycles, and if the outcome is good, I continue to pay. But if the outcome is not good, and if I have to get out of that program, then maybe I don't pay anything, or I pay a small amount. I might pay 10%, 20% of what I've actually spent, and the rest comes back to me in some manner. So those kind of programs are also today helping people access expensive, considered, very, very good and reliable treatment sources. Yeah, so I think these are some of the ways in which I think this program can be considered. Of course, you also have other options like, creating an option where you have a crowdfunding methodology combined with a loan program. So which means that, okay, fine, here is a family which requests 10 lakhs, but they don't have the ability to, borrow 10 lakhs. So bring in a crowdfunding platform, get 5-6 lakhs out of that platform, and the rest 4 or 5 lakhs you lend to them, and then they pay it over a period of time. So those options are also possible. So I suppose these are some of the ways in which we could at least get the middle class, pay for their such a difficult time. Yeah.
Thank you very much. I think you made several important points there. And also I think brought out the, what in insurance we also refer to as the missing middle, that in India we often, we're talking about the poorest, and then, obviously there's certain percentage at the top of the pyramid that can sort of take care of their needs. But what about that big sort of chunk in the middle, people
That's right.
who might not have access to insurance and don't have? So I think that's a very important point, and obviously the linkage between accessibility and financing, being completely linked to each other. So those are some very, very pertinent and important points. Thank you. I'll perhaps go back to Mr. Garg at this stage. And apart from your reflections on what other panelists have shared, also your thoughts on where innovation can really play a role in all of this, because we're talking of financing, and we know that somewhere innovation, whether it's with diagnostics, whether it's making screening more cost effective, whether it's making treatments more cost effective, innovation does have a big role to play. So where do you think we're at when it comes to innovation? What more do we need to do to perhaps create a better enabling ecosystem for innovation? So your thoughts on that would also be great. Thank you.
Thanks, Urvashi. Thank you for the question. I think it's a very, very, very relevant and important area to discuss through. I think innovation in cancer care is very, very important from a perspective where I think it should take care of both sides of the coin. On one side, I think Mr. Peter talked about it. I think on one side of the coin, you're talking about whether the innovation that you are bringing to the fold is making the treatment affordable. On the other side, are you improving the quality of care as well? I think so. It should, to me, it is both sides of the coin, of the same coin, when you talk about innovation. And so, if you really see in last 10 years, and Dr. Lalit, Professor Lalit will talk about it more, I'm sure. The kind of technologies we are seeing now, which are used in cancer treatment, are really, really going notch higher by every passing year, right? I mean, you started with surgical oncology, but then, your radiotherapy picked up, and now you're talking about many other very, you're talking about nuclear therapies, you're talking about proton therapies, and so on and so forth. So you are going closer and closer, which are more specific, more site-specific, more disease-specific, more cancer cell-specific therapies, which are now seeing. And I think technology is playing a big role. You are also getting a lot of newer technologies like cholangioscopy, which is helping the GI cancers a lot. Though they are not very prevalent in our country, but I think they are. If you see the Punjab belt side, GI cancer is very, very common. And I think cholangioscopy is playing a very big role there. So what I'm trying to say here is I think innovation is playing a very important role as far as the clinical outcome is concerned. But I think when it comes to the cost effectiveness. I think that is, again, I'm sorry to go back to my health economics cap, and that's what I intend to do in the whole session, because that's cancer treatment. And that the challenge remains is the question about what constitutes value in a cancer care is a real issue here. Today value is defined as the health outcome, right, per dollar spent. But in case of cancer, there is no definite stage to which a doctor can define, okay, this is the acceptable outcome that I'm doing, or not a technology provider can do that. This is the level of outcome that I can provide. And so I think from a value perspective, it becomes a real difficult thing. So, I mean, in a cardiovascular setup, it is easier, right? Okay, there is a blockage, there is angioplasty done, and the person is really, healthy now with the stent in the heart. But in the case of cancer, and I think Dr. Lalit can talk about more about, but there is no definition of value here, right? I mean, which stage you are entering into the healthcare system, and then in that stage, what care can be given, what outcome can expect. I think those are the challenges we face, and therefore I would, to respond in one sentence, innovation is important. While it should improve the quality of care which exists so far, at the same time, we need to make sure that it is also within the affordable limit, which makes the therapy cost effective, I would say, so that we are able to answer both the questions of clinical outcome and the cost effectiveness. Thank you so much.
Right. No, that's a really important point, and I'll take that to Dr. Kumar as well on the technologies, and also now the digital push that we are actually seeing from the government. We saw the budget also. It's a very, there's a lot of push on digital. Now, of course, we know digital is no substitute, for actual delivery of services, but it can be an important enabler. And your thoughts on how we can really use it in this particular context to make our cancer care more affordable, more accessible. So that would be my one question to you. And the other would be on the screening program that you spoke about. And I think that is something that we are trying to work on through different lenses. The health and wellness centers also, we are trying to bring in screening for NCDs. But really, how do we make this successful at scale, which is obviously what we need to do in a country like India? If you have any sort of thoughts on that as well, that would be very, very, I think that will add a lot to the discussion. Thank you. Dr. Kumar, I think you are on mute. You're possibly speaking on mute.
Okay, so am I audible now?
Yes.
Okay, so I'll just, if you permit me, then I can add to what Peter was saying.
Yes,
like,
please.
I just want to give an example that we had one program called GPAP. This is called Gleevec International Patient Assistance Program. And this is actually one of the revolutionary program. Like in 2000, we had the first targeted therapy for cancer or the chronic myeloid leukemia with the name of Gleevec, which is now imatinib. And the one group, I think the US, the Max Foundation, they came with this program, and now I think more than 19 or 20 countries like India, Bangladesh, Nepal, Pakistan, and all Asian regions and some of the Eastern Europe also, they extended this program. They provided the free Gleevec capsules to everybody till 2015. And by the time in India generic brands came, so they stopped the program. But they still continued to sponsor some of the patients who were registered that time. This helped in two ways. One, that earlier the cost of this drug was per month was almost 100,000 rupees per month. And so therefore, but providing those drugs during that time, it was possible with they collaborated with the Novartis company, which was the kind of making this drug. And they provided for more than 30,000 people all over these countries, which really helped. Now we have the people more than 20 years who are still alive, living good quality of life and doing well. And now since drug has become cheaper, so we are able to provide to almost all the people who come to our hospital. So this is something, so like philanthropic organizations, if they come forward, they can really tie up with some of the drug company or the social cause. I think some of the things which can be explored, and for some of the expensive drug which could be done. So that was just wanted to add to that point. Secondly, you asked about the technology point of view. I think once we have the technology available in many fields in India, especially like imaging, like you have the CT scans are available almost to every street now. PET scans have become available much more than what people will have in the US actually. The PET scan, you can get a PET scan done quickly and it's relatively cheaper. Obviously, it's still not enough because like you consider the whole population and especially the districts and the remote area, rural areas where the people have not been able to reach. So one of the important point would be that like if access can be there for some of these facilities, then the cost will come down and that will save the kind of delay in the starting the treatment, like once your diagnosis is made and all that. Secondly, the major, I think, technology utilization could be now since India has become digital in many areas. So in the health also, the telemedicine already people have started practicing, like for reporting of the radiology. For example, people in the US, they are being, those CT scan, MRI or PET scan are being reported by the people in India and they being sent to them, the reports. So they are able to access those films. And even in India also, like PET scan, I know one of our resident who was just passed out and they are reporting from Bangalore to a hospital in Chandigarh. So similarly, the telemedicine is something which could be very useful, like for the people who have come for the first time to the metro city, for example, cancer center, tertiary care cancer center. So once the treatment is prescribed, then one can really follow them up through the telemedicine or telephonically or emails and other things. And I give you one of the example, like during the COVID crisis last year, we had replied almost 1,300 emails to these people, so we could continue the treatment for most of these people who could actually get the medicine. We still had the problem because the people, those days everything was shut down, so they could not get medicine in time. But this is something I think we really have to work more kind of efficiently, and this really can save a lot of things to the people, and it really has become, and every day almost 8 to 10 emails we still reply to the people who, for small little things, they just want to know what is to be done and all that. So we are able to reply. The third point was about the screening programs. Now the India already has this national health mission, and they already have screening programs for 3 cancers: oral cancers, breast cancer, and the cervical cancer. So any person who is between the 30 to 65 years of age has to be screened in those centers. And this program was actually almost 450 districts. It was implemented till 2 years back. Because of COVID, I think there has been a little setback in that. But was seen by the health workers or ASHA workers or midwives, they will do those kind of screening or clinical examination. And then there's some suspicious, then they will be referred to the PHC or community health center, or from there to the district hospital. And after the biopsy is done, then it is confirmed that it will be referred to the tertiary care center. So that if that program can be implemented to the whole country, I think this will reduce, bring down a big kind of big change. Because I'm saying this because like the oral cancer, which is the major cause, has been the tobacco related. So the people who are, one can identify the people called high risk, and they have inbuilt in that program, like whether do you smoke or how many years and all that. And they do the scoring like that, and then on basis of the scoring, they call them, okay, this is high risk. So then you have to go and do the follow-up on the patients and after the screening. And some of these things are very, very simple. So I think these are something which could be done, apart from the other, which some groups are already doing that.
Right. Thank you very much for that. So I'll go back to Mr. Peter, and I also had one question, and it's related, obviously, to what we've been discussing and the financing part. But really, it's around the heterogeneity of this disease that we talk about. Cancer. It's when we say cancer, but it's not a homogeneous disease. There is so many differences. There's different kinds. There's different stages. So how do you feel? How does that link up to our whole financing part, the kind of offering that we have currently, the product offering that we have? Dr. Kumar was highlighting that, it's not just about the treatment, but for instance, a family which is coming, here to get treated. I mean, they also need to stay. They also need their subsistence, their survival. So it's so complex and it's so heterogeneous. In this landscape, how do we really, truly think about financing? Perhaps we need different kinds of offerings, we need different kinds of products, and how do we go about that? So any thoughts on that that you might have?
Yeah, it just reminded me of recent Google exercise that I was doing, and here was a American citizen requesting for funding support for the gas that he has spent going up and down for his treatment. So the full details were not there, but I presume that his treatment was covered by insurance. So he didn't have to pay for it. But he had to still go for that treatment. And there you have no choice but to use your car to go. And the gas, the cost of gas that he spent multiple times itself is a huge burden for him. So as you rightly said, and then he was looking for funding support for that. So to make the point, yes, it hits different people in different ways. And from a disease point of view, from the funding point of view, people's families' approach to that such patients' point of view, there are multiple challenges, no doubt about it. So and I think there is, to me, there is no one cord stitch. There's no way you can stitch the cord a single way. And the problem is so huge that you can't think about everything together and then address. While we can think through whatever you can, you keep addressing what you can, and and hoping that that is contributing to that overall solution. So different people will have to contribute from different angles. So for the middle and the lower middle class, financial institutions, innovative ones can certainly make a pitch to try and reduce or alleviate that pain. And also, what I also realize is that, assuming that the genomic tests, the immunotherapies and the targeted therapies are good things to do, how do you bring down those costs? Okay, one is bringing down that cost from a point of view of, okay, somebody reducing that cost and making it, support programs, etc. But if the usage increases, the cost will anyway come down. So it's a chicken and egg situation. So somewhere it has to begin. So you bring down the cost as much as you can and somehow push the usage. Okay, so from every angle, from insurance, from financing angle, from every angle, you push those usages, and when the usage goes up, costs will come down. So I think that's one way. I feel we can address that situation. Generics and all that, of course, are another way, but that is coming from the supply side. But from the demand side, also I think we can look to reduce costs. So that's one way I think you could address that problem. Was there any other question left which I didn't answer?
No, I think you covered.
Yeah.
I think Dr. Kumar wanted to add.
So I just what Peter just now said, that encouraging the India actually has been able to have good success in the terms of that we have generic medicines or biosimilar medicines. So for some of the medicines which are not patented till 5 years back, so we had a good number of medicines. Like I gave you example of Gleevec. Now we have about 2,000 rupees per month treatment. Similarly, for the lung cancer, breast cancer, and many of these cancers, we have some of these targeted therapies and generic molecules which people are able to use. They are still maybe unaffordable for many patients from the rural area, but at least they are now available. They are affordable at least for the some of the patients from the urban area.
Yeah.
I think this.
Yes. Yeah. So in fact, yeah. Thank you, Doctor.
And secondly, the government now the Amrit pharmacy or Jan Aushadhi outlets, which government has made in some of the states, like they are probably more than I think 19 or 20, which are one of the very good in the sense that they negotiate the bulk price of these medicines. So the cost has come down to by 50%, 55% or 60%, which is, so if we can do the quality control also in these, so they don't simply just dump some of the bad things, but if we can maintain this quality and on all the districts and the state level, I think this will also be one of the, and which can be done easily. I mean, it has been shown, like, I mean, we have been seeing that kind of thing in our institute, that the cost has really come down for some of these medicines which were otherwise the printed. And thirdly, that the 2 years back, government bring down 42 cancer medicines under the so-called essential medicine list, which brought down the cost to, because earlier the printed price was like 14,000, 12,000. And in fact, the market, you could get that easily for 3,000 or 4,000 rupees. So the chemists were making huge margins. But now what government has done, that you can fix the price, like for that medicine, they fixed 2,400. You cannot exceed more than that. So at least there is a big relief. So people, and now with the competitiveness in this market, so there is the price of these list have, the cost of the medicines have come down. So some of those, I think, innovations in the bulk purchasing, promoting generic medicines, and obviously the augmenting the research, so that how all this can be done, and some of these, especially the India-centric problems, I think that will be a really big help to the patients. That's what I'm saying.
Just to add on one point to what Dr. Garg was mentioning earlier about the outcomes and how do you know what the economic aspects and all that he mentioned. So just to give an example of Arogya Finance, when we started getting brave enough to start financing cancer treatment, which initially we were not, because we were too concerned about outcomes and things like that. When we started doing that, one thing that we did was we did not want to look at outcomes at all. Because the moment you start thinking about what stage the patient is and whether what will be the outcome of the therapy, etc., you don't feel confident. So what we decided was that is entirely between the families, the patient, the families, and the doctor. They know best. We know nothing in any case. Okay, so don't worry too much about the disease and its outcomes. That there are others who are looking after those issues. You see whether they have good intent to repay and whether they have the reasonable capabilities to repay. Go out and finance it. Don't worry about outcomes. So that is the approach that we have taken, and we ensured that there is no doctor on our panel, because the moment you have a doctor on the panel, you get self-doubts, and for right reasons. I'm not saying for wrong reasons, but we didn't want to get those doubts. So we kept it a completely a financial decision rather than anything to do with the therapy and outcomes, and that has worked well. And that has worked well for the patients and families as well, because if they are going there and treating that patient, they know what they are doing, they know their capabilities, they know what they want as an outcome from that. Who are we to sit in judgment on that? We should just look at and see whether we could help them, and that's what we have been doing, and that has worked well for us.
Just if you allow me, then I can add one more point
please.
here. Now, one of the major problems which we face in our country is that people do not adhere to the guidelines. And there are no strict guidelines. For example, early stage 1 and 2, generally people will say, okay, localized treatment, surgery or radiation. So that part generally is okay. But in advanced disease, and some of these new molecules which have come like immunotherapy, immune checkpoint inhibitors we call them, and some of these targeted therapy which are introduced in last 5 or 6 years. Benefit of many of these drugs is just only 4 weeks or 6 weeks. So if you get a person from any like middle class or even lower class or any poor background, and if you that okay, somebody gives them not a proper guide, proper advice, okay, this new medicine will do wonders. The poor fellow will try to sell his house, sell his jewelry, sell his everything, and then okay, the doctor has assured me. So and then he realizes after one cycle he's run out of the money. So if we can ensure that we follow certain guidelines by whether the ICMR takes the initiative or some other organization takes the initiative, like we in the UK, you have the nice guidelines. So people have to follow them, and only then there will be kind of reimbursement will take place. In India, since the people have to pay from their own pocket, so that question does not arise except 10 or 15% who may have insurance. But even there also they just, do not follow. So we really have to have some sort of control on that guidelines for each individual disease. So as you said, the variation from one hospital to another, corporate to government hospitals, or smaller to larger hospitals, this variation can be minimized. So the cost definitely will come down, that you first do the certain set of treatment which is recommended, that should be done, and then only there is some experimental treatment, and for if we have some research protocols or research funding available, and under which that can be done. So that can be encouraged, like one can find out and popularize what are those centers having those research studies going on, and the patient particular cancer, if they have some research, then they can go into those centers to get enrolled for themselves.
Right, right. And I think those are really important points. In fact, when we were discussing the Ayushman Bharat packages also, I think we brought these up, and I think we will continue to focus that, we need these standard treatment guidelines. We also need to communicate them very transparently, because, healthcare, anyway, being a field where there is so much information asymmetry, for a patient, for their family to really be able to understand, fully what's going on, it is difficult. So how transparent we can be, how we can communicate this to everyone, all concerned, I think that is also something that we really need to focus on, even as we design our insurance programs. And so thank you, doctor, for that. So we have around 10 11 minutes or so I thought we'll have one final round of comments from all our panelists, and if you can also just share your thoughts. We'll begin with Mr. Garg. In terms of any specific points that you think any of the stakeholders should be looking at. These could be small actionable points. As Mr. Peter said, it's a huge space, we can't address everything all at once, but maybe there are some relatively small simple things that different stakeholders can start doing, which can make a difference ultimately to patients, their families, to their quality of life. So it would be great to have thoughts from all the panelists on this as well. We'll begin with Mr. Garg.
Thank you, Urvashi, for those questions so far. I think Dr. Lalit created a fantastic pitch for a person like me as a health economist to play my shots on that. So, I think he brought a very important point on the reimbursement models in the country, right? We are struggling as a country. Howsoever number of schemes you bring, if you don't have proper reimbursement, appropriate reimbursement, we will not get the desired outcomes that we intend to. Health technology assessment by the Department of Health Research is a great move in that direction, but still we have a long way to go. Now, for a family, the patient is very important, right? Because the patient is a family member. But for government, the budget is limited, right? You talk about Ayushman Bharat, you talk about any other scheme, you have take an example of if the government has 10,000 crore to spend on cancer, they would want to bring the best outcome of these 10,000 crore rupees. And that can only come if you have proper health economics models, which are suggesting you as to how many dailies or queries are you really care for. And I think that's where it is important for us to come back to the discussion of that value. I totally understand. 10,000 crore rupees is a very small amount, right? But if you have a proper health economics models, which are suggesting you as to how many dailies or queries are you really care for, and I think that's where it is important for us to come back to the discussion of that value. I totally understand. 10,000 crore rupees is a very small amount, right? But if you have a proper health economics models, which are suggesting you as to how many dailies or queries are you really care for, and I think that's where it is important for us to come back to the discussion of that value. I totally understand. 10,000 crore rupees is a very small amount, right? But if you have a proper health economics models, which are suggesting you as to how many dailies or queries are you really care for, and I think that's where it is important for us to come back to the discussion of that value. I totally understand. 10,000 crore rupees is a very small amount, right? But if you have a proper health economics models, which are suggesting you as to how many dailies or queries are you really care for, and I think that's where it is important for us to come back to the dis understand the perspective that Mr. Peter's model is financing the patient. But if you see from an overall health economic burden because of the cancer as a disease, we as a country need to do a much better job to define those health economics model, which can provide better outcomes in the same amount of money that you're talking about, right? Whether it is to do more work on the diagnostic side of it, to do more work on the prevention side of it, or to also try and see, can we push more patient early in the healthcare system than the later, and you want to create more awareness around it. So I think with a limited budget, the health economics model taking care of all four stages, the prevention, the diagnostic, the therapeutic, and the palliative, right? So how do we really create those programs which are addressing these challenges through the right health economics model? And again, as Dr. Lalit was talking about, health technology assessment is another tool that we need to really work upon. Newer technologies will keep coming, but what kind of promises do they have when it comes to the outcome, I think is very, very important, right? The amount of money getting in versus the outcome you are expecting, I think those comparisons need to have from a health economics perspective as well. So thank you, Dr. Urvashi. I sort of give rest to my comments there. Thank you.
Thank you so much, and I think we've really gained a lot from your comments. You've been wearing the health economics hat, as you said. So I think we really gained a lot from that perspective. So I'll move on to Mr. Peter, please, for your concluding remarks.
Yeah. So I would like to stay with the financing or the making cancer and healthcare, overall affordable point of view. So from that point of view, if you really look at it, as I mentioned, the Ayushman Bharat is taking care of a significant part of that burden at the bottom. Top is looking after themselves. There is no problem there. It is the missing middle that the real issue is. The sad reality to my mind is, it is the fear of healthcare, cancer, healthcare, all of these words, the financial institutions are generally afraid of. And that is creating the problem. Our experience in the last few years shows us that here is a set of people who have reasonable capabilities to pay for themselves. Okay, out-of-pocket expense, fine. I don't have insurance or inadequate insurance, but I still have the capability to pay for it. Only if there was somebody to help me, create those options for me. If I were to buy a smartphone, there are 100 people there out who wants to finance me. If I want to go for a holiday, there are enough number of people who are very happy to finance me. But when it comes to healthcare, nobody wants to finance me. Now, that is the problem, according to me. And it is not their lack of capabilities. It is not their, their intent, which is the problem. It is us as an organized, as a country and at financial institutions, we are too afraid to move. Even we were afraid, okay, to be honest. Okay, so I think if we are able to get that fear out of the way, lots of these out-of-pocket expenses, especially by the middle class, can be taken care of by themselves, and they can really afford. They can ensure that they don't fall into that trap of poverty by issues. So I think there are institutions who are working to create that kind of situation where demonstrating that yes, these can be financed and the outcomes are good, the portfolio can be managed, all of those. So if more and more examples like that gets created, and if more and more financial institutions can then take up that challenge, then I think significant part of that burden can be taken care of.
Right. Thank you very much. And we'll request the final word from Dr. Kumar, please.
Yeah, so I'll just try to summarize like 4 or 5 points which we just discussed. And obviously the one is apart from the budget, which government obviously you'd like more and more budget to be given to this sector. The awareness probably is still one of the keywords that we have to find some methods to improve the awareness about this disease. And having more cancer centers which are within reach, 50 to 100 miles, people can reach there and can get their diagnostics and treatment done there. and obviously that more research and the India-centric diseases, cancers like cervix and breast and lung. There are some differences to try to really see that, and drugs like generic and biosimilar drugs, more and more drugs. And also we, I think forget that time, the cancer registry, we already have 34 population-based cancer registry and 64 hospital-based cancer registry as of now. But we really need to have in each district so that we really know what is the kind of volume of the patient which are coming from there. And secondly, I must also say that here that cancer is notifiable disease only in 12 states. It is still not a notifiable disease in the remaining states. So each state should issue that kind of, that will improve the registration of these patients and a proper correct numbers will have the correct assessment. As of now, this is based only on the 10 or 12% of the total population. We make the assumption that the incidence and the prevalence and all that. That is, I think we need to really improve on that and have probably certain guidelines. People need to adhere to those guidelines and some strategy like telemedicine, other things for not only for treatment monitoring, but also for the follow-ups. So I think some of these things probably should go in long way, and we are on the track, but then it has to be a little speeded up.
Right, right. Thank you very much, Dr. Kumar, and also Mr. Peter, Mr. Garg. I think we had a very vast topic when I first looked at it. There's so much to cover in 1 hour, but I think we did manage to cover a lot of ground. So thank you very much to all our panelists, and I think we're just about coming up to the next session. So we finished in good time. I'll hand over to the next session to Dr. Nalini Kaushik. Thank you so much.
Thank you so much. Thank you.
Thank you so much, Ms. Prasad. And that was definitely, a very insightful session and a conversation where, all the stakeholders stressed upon the nuances of financing and particularly the universal health coverage in the cancer space. And I think which is definitely the need of the hour. And moving forward, so good afternoon, everyone. I am Dr. Nalini Kaushik and welcome you all on behalf of the Integrated Health and Wellbeing Council as we observe the World Cancer Day 2022. So at the outset, I would like to reiterate the broader significance of this day, which is to prevent millions of deaths each year by raising awareness and education about cancer and pressing the governments and individuals across the world to take action against this deadly disease. So therefore, reiterating the same intention, we are here with some of the most eminent stakeholders from the cancer community to discuss how to accelerate equitable access by forging cross-sectoral partnerships and collaboration in the cancer space. So without losing a lot of time, I would straight away go to, introducing our panelists and begin today's conversation. So we have with us Dr. M.R. Rajagopal, Chairman, Pallium India, Mr. Somesh Kumar, Country Director, Jipaigo, India, Dr. Sushma Bhatnagar, Head Department of Onco-Anesthesia, Pain, Palliative Care, AIMS, New Delhi, Mr. Maulik Choksi, who is the Director at Health Systems at Access Health International, Mr. Somil Modi, General Manager, Novartis Oncology, Dr. Shibu Vijayan, he is the Global TB Technical Director at PATH, Mrs. Jyotsna Govil, Chairman of Indian Cancer Society, New Delhi, and last but not the least, Ms. Anu Acharya, CEO, Map My Genome India. Thank you so much, and definitely this seems like a very star-studded session today, and it's an absolute honor, frankly, for me to be hosting this session with some of the most senior faces from the scientific, medical, patient advocate stakeholder community of our country. And so without losing a lot of time, I would straight away go to our discussion and say, to set the context, I would begin the conversation with Dr. Rajagopal. Thank you so much, sir, for joining us today. So as you know that, in this panel, we are discussing, how different actors are working or can work together to improve access and break the silos, across cancer control spectrum. So what do you think, cross collaborations mean when it comes to cancer care, and what kind of collaborations are really needed to build, stronger and sustainable solutions in the cancer ecosystem. Over to you, sir. Sir, could you please unmute yourself?
Of course.
Thank you.
Sorry about that, Nalini. And thank you for the question. Very relevant. Cancer treatment is now the domain of oncology centers and oncologists. And that's great. But should it be only theirs? Should we be collaborating with the rest of the community? What is the patient's and family's element of suffering? It is not only the growth. It is not only that cancer somewhere. It is the fear, the anxiety. It is certainly the catastrophic health expenditure that the family will go through so that the next generation also gets destroyed. It is the break in relationships, as too often happens in our country. When a woman gets cancer of the cervix uterine or of the breast, being abandoned by the partner and maybe relegated to the outskirts of the society even. So the woman's self-loathing and the feeling, why did my God desert me? The suffering is all this. And we as healthcare providers have a duty to treat suffering. This is not only a personal opinion. The Bioethics Unit of Indian Council of Medical Research has put it down in writing. The healthcare provider's duty of care is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. And the ICMR adds, there exists no exception to this rule. This relief of suffering cannot be done by doctors alone and doctors or nurses together. This is where the non-government organization, civil society, the community around the patient all have to come together.
Right. Absolutely. Thank you so much, sir, for, pointing that out, because as we are discussing, cancer ecosystem, cancer care, the situation and the plight of a patient is really important, aspect that we more often than not end up forgetting. And I think you have really set the context right, that, it is for the patient at the core, which require, these sort of cross-sectoral partnerships, because it's the patient and the life that really matters. So with this context, I would, move to Mr. Somesh Kumar and Mr. Maulik Choksi, because both of your organizations, you've been playing very critical role to support many programmatic interventions and sort of ease off, the implementation of various programs. And what Dr. Rajgopal just said, that, it is, the course of patient's life, which needs to be, central here. So your organization have been actually doing a lot of work in that space. So by that experience, what are some of the collaborations from experience, across the healthcare and cancer communities that are really working successfully? But in the future, and what kind of collaborations we need to build further? So over to you, Mr. Somesh, we would start with you.
Sure. Thank you, Nalini. Thank you for having me in this conversation. I think if you look at it very simplistically, if there is one disease which requires engagement of non-health collaborators and stakeholders, with health collaborators, cancer would probably one of these, because it's many diseases rolled into one. And Dr. Rajgopal very rightly talked about the suffering element to it, and we all know the entrenched gender dimensions of both problems in accessing care, as well as then continuing care, as well as then living with the disease for the rest of the life. So this obviously needs a cross-sectoral approach, where you want to go to those folks who really can address some of these very deeply rooted asymmetries of power, asymmetries of information, asymmetries of agencies and information within the communities and our societies in which our cancer clients living with cancer live in.
Yeah.
So just as for me, collaboration, I typically take a problem-centric approach. So, what are we trying to solve here?
Yeah.
And so just a couple of examples, like if you go to first accessing care, or even under women not being aware about, the need for 5-yearly breast examination or cervical cancer screening. How do you reach those women in a rural community or in an urban community? So you can, we have partnered, for example, with self-help groups to reach to those women through really large numbers through the peer-to-peer, conversations, and you just need to catalyze it once and twice, and it just goes like fire. And in South Africa, we have been partnering with malls, for example, for creating those small chambers where women can be offered screening services as a part of their entire shopping experience. And of course the marketing goes with it, everything. So and I have so many more examples that we can talk about later in the conversation, but it was just one example of how you need to just understand, what problem are you trying to solve. Even for example, financial access, we have tried to partner with microcredit institutions. How how on earth can somebody buy a car with microcredit institution and not access the catastrophic cancer expenses? Microcredit institutions, credit institutions to address some of the financial barriers. So taking a problem-centric approach and then identifying who is the best suited to solve this specific problem for this specific community really helps.
Right. Thank you, Dr. Somesh, because I think if I sort of contextualize your response, I think this is more on the lines of decentralization of cancer care. And I think that's, if time permits today, we would definitely want to go back and circle back to that conversation, because one of the problem that we still face in our country, despite all sort of health solutions that we have built in, is decentralizing the cancer care. And I think we would definitely go back and circle back to you on that part. Mr. Maulik, your turn, I think. Over to you.
Thank you, Nalini, and thanks for having me here. I think so. I would decentralization. I would add another word to that, is defragmentation, right?
Absolutely.
And so I would say, and for us, I think so. That's what we kind of work on, in kind of defragmenting ecosystem, because when we talk about out-of-pocket expenditure, one end, right? When we talk about palliative care, which Dr. Rajagopal mentioned about, we talk about kind of in previous session, and I think so. There would be a reference of early diagnostics. We are talking about healthcare financing, public and private. At the moment, these are defragmented systems that are existing in our ecosystem. And I think so when we talk about a patient, right? A patient, when he enters health system, I think so we need to defragment this kind of stuff, so make that his journey becomes easier. And I think so that kind of decreases a lot of kind of anxiety. Anxiety has got its correlation with health outcomes, right? That health outcome, that correlation with out-of-pocket expenditure. So I think so that defragmenting your ecosystem is very, very important. And the most crucial example, we need to kind of move towards early diagnostic systems that we need to kind of get into place. I think so in our national programs, right? We have national programs, but at the moment at reimbursement levels, the national programs need to kind of include reimbursement of early diagnostic. And when it happens, both again, the quality of care to the patient improves, right? Vis-a-vis the health system perspective, the out-of-pocket expenditure and the overall health expenditure of system increases, because now you don't need to go for invasive treatment. I think a lot of things could be addressed at much earlier stages. So what we kind of work towards is defragmented ecosystem, so that both at the efficiency of system improves, the efficiency of input at a patient level improves, and that improves the quality of care that has been delivered to patient. And system level, Tamil Nadu is a good example that one can look into, right? When cancer care started, I'm talking about 7-8, right? Cervical cancer. It was a development partner who supported the state of Tamil Nadu to pilot early screening in a small scale. Now it is a full-scale program which is funded by state. So as Somesh did mention also, that we need small pilots to kind of test our kind of idea, And then idea itself is to defragment it in a manner that you've got continuum of care which is delivered. And the most crucial component that would be knowledge creation, that each and every step is documented. We have got knowledge that we can pass on from one to another, both success as well as failures. You're not always going to be successful, you're going to fail. And how do we fail in saying that this defragmentation approach did not work? And that's what I think will help kind of changing ecosystem on a broader level. Thank you.
Thank you so much, Mr. Maulik. And I know that you have a positive time. You have to move to another session of yours today. So I have a follow-up question for you that, thank you so much, first of all, talking about or adding another dimension, which is decentralization, but also defragmentation. And I think which is a critical need of the hour for us or, in our country. At the same time, you just talked about knowledge creation and, sharing and resharing of that. And I think that's where I think another intersectional, support from the different stakeholders come, into question. So how do you think, yes, I think in our country, we are doing a lot of knowledge creation. We have a lot of pool of, knowledge. And if I see all the faces, here on the panel, this is the knowledge that we have. But how do we bridge? Because there are silos here in which we operate. How do we sort of bridge that and, build further on it?
So I'll tell you, this is one of the efforts that we have put in. We are building an India Health System Collaborative, and we are bringing Global Learning Collaborative. India Health System Collaborative is a systems level collaborative. We have about 1,600 health systems researchers coming together. Now, I think so at systemic level, again, defragmenting, right? The policy agenda which this health system researchers is to focus needs to be driven by policymakers who are going to design policy, but also practitioners, right? Colleagues like Dr. Madan Gopal or Somesh or Jyotsna needs to come together and say that, hey, within our field, this is what the knowledge needs are. This is the knowledge needs that already exist. So there needs to be an aggregator of somewhere, because again, I believe that we are recreating a lot of fields at multiple levels. And the only reason why recreating those fields is that we don't know that's existing, or at times we feel we are better than other people, right? And we need to bring this cohesion in thought process of policymakers and those. And it's not an easy approach. Right? It takes, Somesh will can vouch, and Shibu is also here will vouch that this kind of processes are not easy when we bring public sector and private sector colleagues together. It's one of the most challenging aspect when you got public sector and private sector together with kind of the word I'm using now very powerful, the mistrust between those two partners, right? When those things comes and we want to create this ecosystem, fragment ecosystem is the real kind of efforts required.
Right, absolutely. And I think you've used one very powerful word. You said, mistrust. But while we know that there is, to some extent, there is sort of, asymmetrical approach or maybe some mistrust, but also we know that once we bridge that thing, we have seen many, brilliant solutions also, at a delivery level. So therefore, we know that, once we break it, we have a lot of, significant solutions waiting for us. And I think this gives me an opportunity to bring in Mr. Saumil Modi, because he represents, another, spectrum, of, the stakeholder groups that, which are really critical to, solution side of cancer care. So, Mr. Modi, we have heard, these experts right now, who while represent a different, environment, yet they're interconnected in a certain context. So therefore, how do you think that, a private sector company, can leverage whatever, we have heard until now and these kind of collaborations, and build in more capabilities either to support the government or non-government, stakeholders, over to you.
Yeah, thanks. Thanks, Nalini. And first of all, a big thank you to IHW for inviting me for today's panel discussion as well. And as Maulik and Dr. Rajgopal also said, right, at the end of the day, there are multiple ideas on the table, but how do we mix and marriage that, and how do we ensure that the patient who's suffering at the end of the day receives it? So I'll quote a few examples as to how we've been partnering with various patient groups. We've been partnering with Japaigo, with a lot of other agencies in terms of how do we do it. So from our country perspective is, you may have medicines completely free of cost, right? But the whole problem is the infrastructure or the holistic ecosystem that we have, because that's an area where there's a huge gap. Now, even if we create hospitals through Ayushman Bharat, you will make everything available, but administration of that or knowledge of the physicians who are sitting at the primary care or the secondary care health centers, it's very important. Fortunately, I think the one good positive spin-off I would say of COVID is that because of the disruption in digital, everyone's so well connected now.
Right.
And I would take an example of sickle cell, where what we've done over the last 18 months is states like Madhya Pradesh, states like Orissa, Maharashtra, Gujarat, we've gone much deeper. So there is collaborated with the tribal ministry. They have selected a group of experts, and then we going and educating the doctors who are in the CHCs and the PHCs on what are the symptoms of sickle cell. See, a lot of people don't even understand that it's a disease. So that grassroots level education is very important. To give you another example, I mean, Somesh is there. We work with Japaigo in Orissa, and that's primarily aimed at increasing the awareness and competencies of the doctors on screening of breast cancer. So here the whole objective being that as an organization, if we decide to partner, if we have that intent that we want to create, I think there are a lot of expertise across the room, there are a lot of expertise which are available, which can be leveraged and which can be done. The only point here being that it has to be standardized, because to give you an example, I mean, oncology is so fragmented that it's like where you land up, right? So today, if I have a lump and I land up at a radiation oncologist, the thought process is that, okay, radiation is the way to go. You land up with a surgeon, irrespective surgery. You land up with a medical oncologist, do this. So I think that standardization of treatment or standardization of care, which is there, even at the lowest level, I think through all the digital technology that we have, if we can really leverage that, and we have standard protocols. Everyone runs their own protocols, but if the government or through Ayushman Bharat or National Cancer Grid, they come up saying that during screening, this is the protocol to be followed. During this is the protocol to be followed.
Right.
And then if we are able to really take it to the last mile, I think between public and private, there is enough opportunity to work together. I mean, although I come from a multinational company, but I think there are enough and more opportunities where we can work with the state governments, we can work with the NGOs and create these solutions where we can really make a strong ecosystem of care.
Absolutely. Thank you so much, Mr. Modi. And you just talked about, like we have been building upon the same conversation of defragmentization, and, and you further built upon it and said that, standard protocols, right? And that's actually, which is, I think if I perceive it as, different actors coming together, but you have standard protocols at the center, I think adhering to that and,
completely now. It's completely moved to tablets, it's moved to targeted therapies.
Yeah.
But that's not a part which is even considered, that we should be looking at reimbursing the patient this. But Ayushman Bharat has already taken that step, because a lot of representation happened to them saying that, look, what you're doing is great, because people who were never thinking that they would get some cancer treatment, today because of Ayushman Bharat, they're getting some treatment. But the world is moving. Now you can actually do orals, you can do much more. The patient need not even come to the hospital. So they are open to doing all these things. So if we can really take these examples to the government, to the National Cancer Grid, to Ayushman Bharat, I'm sure they can have a process by which it can be cascaded down to the PHCs, CSCs, and so on.
Right. Thank you so much, Mr. Modi. And I think if you're talking about standardizing the protocols and, this is a conversation at a regulatory level, and then, further implementing that. This thought I would like to, with this thought, I would like to invite Dr. Sushma Bhatnagar and also at a certain point, Dr. Rajagopal, that ma'am, when it comes to, supporting the regulatory side, or, because you have played a very significant role in mainstreaming palliative care in India, and shaping even the NDPS Act, and needless to say that such actions have they require a multi-stakeholder support. This kind of support is at its core. So, from your experience of that palliative care in India, and which I'm sure you're continuing to work in that area, because the implementation of this particular policy has been really challenging, in our country. So, where do you think you brought in, or where do you think was the role, what was the role played by these multi-stakeholder collaborations, and where do you think we need to add more support when it comes to palliative care and acts like NDPS amendment acts and all?
Thank you, Nalini. Thank you very much for the invitation. As far as palliative care is, I think this whatever lag has happened is happened because of because it is basically I can say that in last 30-40 years everything this word has come to India. But as far as the development of palliative medicine is concerned, it is growing well in India, but it is fragmented, and we need multi specialty or multidisciplinary approach. So in all the hospitals, if we will create a system that when a patient is entering in the hospital, most of the patients are in the advanced stage. So rather than they are going to surgical, medical, or radiation oncologist, if a patient will be looked after by all the 4 specialists, that is what aims we have created the system. So, that time only we will be able to decide that where this patient should go and what the patient should plan. Means like if they are registering in palliative care, it does not mean that medical or surgical oncologist will not take care, but they will be also. So one protocol and policies we need, that whole of the country should be like this. Otherwise, what I have seen, cancer patients, they are coming in advanced stage, they are roaming around, sometime in the private hospital, sometime in the government hospital. They don't know anything. They don't know anything means anything. They are almost dying, they are almost in the end stage, but they are still have been offered. Today only I have seen one patient in the OPD offered all sorts of treatment. All sorts of treatment means everything. But once we have explained, he was also able to understand that this is what the right thing, which is so this kind of although palliative care community is making this kind of protocol and government is also helping, but again I say that a lot of people are doing a lot of things, but we are not, again everything is not collating, and a lot of efforts are going on in various directions. So that is why regarding NDPS Act, what I want to say, Nalini, that when the ministry or whosoever is in the policy makers, when they are making, they should involve the right people for the final when they are making the policies, because when comes to NDPS Act, everybody is worried about misuse and overuse, but they are not worried that there are millions of patients are deprived of all these medication. So there has to be a balance between misuse and overuse, and we need to make a the policy maker, when they will call or they will invite the right people when they are finalizing the policy. I think there will be a balance. Otherwise, if you will call only the de-addiction program people, they will say that this causes addiction, and there will be no balance at all. So this is the reason. I think whatever previously said, defragmentation is there. We have to come out with all sorts of everybody is doing very wonderful work, but they are not talking to each other. So that's why this is happening. Department, for example, Department of Revenue is working for NDPS Act. They are doing wonderful job. They don't want to create misuse or overuse, but it does not mean that we can remain millions of people can remain deprived. So they are trying, they are listening, but with a lot of efforts they are listening to us.
Thank you so much, ma'am. And I completely agree, because the journey that, has unfolded for palliative care has been sort of a difficult one. But yet you're right that people are hearing. However, again, the question of some, people working in silos, and there are no interconnected bridges there. So therefore, that's where the manifestation of that happens at an implementation level, because it is really not reaching the patients. While the beginning is that we have to do something for the patient, but then at the end, the end result is not met.
I absolutely says that when patient comes, we are like so many people are doing in India, so many things about cancer patients. But when we see the poor patient, I really feel bad that nothing we have done. So where are our efforts are going? So we don't know about this. We don't know.
Ma'am, do you think there are some solutions that you can recommend today? I mean, they might be far-fetched, but there must be some solutions, because you are sitting at a position and a place where you are, at an intersection, or patients and the policy world, and you're at the middle of that. So from your perspective, what would be the plausible solutions?
So one possible solution is standardization of protocol and policies all over India, because even if the patient will come to PHC, should be the same protocol. So then when he will come to us, we are already very sure that this has been done with the patient, and the same thing we will do. Otherwise, everyone is starting right from the beginning. Patient is coming in one hospital, one is advising MRI, another one is advising PET scan, another one is advising CT scan. Same patient, so many investigation, big thala, they are coming to the hospital, and nothing has been done for the patient, nothing. So I think standardization of protocol and policies, and all the stakeholders, those who are working in all over India, for example, somebody is working in the screening area, they should come together and they should make a group of people. Somebody should be leading that group, and similarly the people, those who are making the standard for treatment plan, I think all of them should come together. So and then NGOs, those who are working, they should come together. There are so many NGOs working, but they are working fantastically well as far as their work is concerned, but they should also make the same protocol. And I think a standardization of protocol and policy for whole of the country will make a huge difference.
Absolutely. Thank you, ma'am. And I think that's one sentiment which, have come very strongly in this conversation so far, which is standardization of protocols and policies. Dr. Rajagopal, just moving forward to you, because we just heard Sushma ma'am talking about palliative care, and you have also, your organization have been very strongly working in this space. So do you have anything to add in whatever, ma'am has spoken so far?
I certainly agree with whatever Dr. Sushma Bhatnagar has said. Yes, let us also think of how this can happen. How exactly will we ensure? Suppose you create all the protocols, they are there.
Yeah.
Remember, 65% of all healthcare in India is on the private sector. 35% is distributed between the government systems, central and state governments. How do we get everybody to follow the protocol? Are we going to create a law making that mandatory? Is that feasible? Fortunately, there are some solutions right in front of us. I think one of the most promising initiatives is that of the National Cancer Grid, headed by Dr. C.S. Pramesh in Mumbai, and which is getting together more than 245, I'm sorry, I'm not sure of the exact number, cancer organizations together, collectively discussing, agreeing on protocols. And some of them are, the Choosing Wisely India. Choosing Wisely India is such a phenomenal achievement. What is necessary? We also need a collective understanding and a collective decision of implementing it. It says somebody with advanced metastatic cancer should not be treated in the intensive care unit. And how does that translate into action? Now, this implementation protocol gap is what we need to fill, and organize it, and collaboratives like ISW Council certainly will have a lot to do about it through National Cancer Grid.
Thank you. Thank you so much, Dr. Rajagopal. And moving forward, I would, loop in Dr. Shibu Vijayan and Mrs. Jyotsna Govil, because to both of you, actually, for now, we have so far discussed, most of the challenges and how, the collaborations can come into picture. And we have heard, of course, certain solutions also, moving forward, which we should be talking about and implementing them. But having said that, I think we cannot take away from the fact that, there have been certain remarkable developments also, in this particular space that has taken place. And there has been, significant reductions when it comes to, certain risk factors. People's awareness to a certain extent has also grown. Treatment inequities, of course, however, and, is still remain a problem. And the levels of out-of-pocket spending have also not really changed significantly. And both of you, again, one of you represents, the implementation side of the world, and ma'am represents, a very, important stakeholder group, which is patients, So what do you think, from your side of world that you represent, how significant are these sectoral, cross-sectoral partnerships, and how do we bridge those gaps? Like we say that, private and public partnerships needs to happen. We need to break the mistrust that exists, because we are, again, we are leveraging digital technology at a very rampant rate now. So till the time we do not bridge, those mistrusts and build stronger partnerships, I don't think, we would be able to build some concrete results. So Dr. Shibu, in your opinion, what are the challenges and what are the way forwards here?
Yeah, I think there is an intent to collaborate that has been actually kind of stated here, and also the government so the sole honor of any healthcare delivery is lying with the government. When I say government, this is the public system. And we also discussed about the private system. There is actually wealth of information and expertise lying in the private sector. How do we collaborate? So my experience essentially is engaging with the private sector for tuberculosis care. The tuberculosis is an indicated disease, I would say. Because that is actually, for us, that was a password to penetrate into the private system. So earlier to that initiative, it was that the government, the government hat is always policing. I have this regulation, fall in line. Or even maximum, if you look at, they are contractors of service. Like I pay you a certain amount or you agree on that amount and deliver on it. There is no partnership in that spirit of partnership. Partnership comes with all these things what we discussed about. Are they in your room? To kind of design the protocols? Are they consulted? Are they being continuously corrected? Are there efforts that actually jointly stack together and came up with joint solution, which has never been done. So we always see that, okay, you are not the one, you are the bad one, and I am the good one. I have all these protocols. You fall in line. Otherwise, we are not going to engage with. So there is primarily the philosophy is a disengaging policy premise, and that actually, I would say that first we need to capacitate government to engage with the private. That culture is of engaging and partnering in the true spirit of partnering. It's not a contract given for building a road. It's actually a patient care. So there has to be a collaboration between both of them, because that's an important public responsibilities in the private also to sharing information, sourcing the government benefits for their patients, and also the drugs and diagnostics. Then you increase the market. So that decentralization itself for care, I'm just saying, so not for screening and all these things, because itself will actually address the out-of-pocket expenditure. I don't have to go to Delhi to get my care. I can probably get it in my neighborhood from a doctor which I'm trusting from a hospital. Then you find out a vehicle for, then the rest of it is secondary. Then you can actually talk to your pharma industry to mitigate right sizing the pricing. That also comes with the standardization, which has been reiterated here. So when you have a package which can pretty much in a defined way, the government also, or the stakeholders also can actually cost it in the right way to build that into a package. Then digital comes into play, right? And digital is actually a kind of enabled transactional, transparency, and also help in mitigating all these things in a better place. And I would say the single thing what we want to agree that before we leaving this room is like, if let's actually perceive for private sector engagement, not from a larger private sector, at least a single private provider engagement. You all know that you are in this cancer space. You all know that who are the key providers here, and we can just start from that. Then the solutions will follow. So that's my proposition to start with. And given the experience from, from the tuberculosis space, and then helping the government in providing that guidance document, how to engage with the private sector from an outcome-based financing, not from okay, you do that and you do this. I'll come back to the later part, for subsequent discussions.
Right. Thank you so much, Dr. Shibu. And adding on to that, we have Mrs. Jyotsna Govil. Ma'am, thank you so much for being here with us today. And please, your thoughts on this.
Thank you, Nalini. I don't know if you can hear me.
We can, ma'am. You're absolutely wrong. Yeah.
It's a pleasure to be with you, and a special pleasure to realize that the doctors on this panel are speaking the same language as the patient advocates. It's really good that that change has come. Nobody is dictating to the patients what they must do.
Yeah.
People like Dr. Rajagopal and Sushmaji actually consult with the patients, listen to them, which is very important. When we talk of access to healthcare, I think the patient's voice is very important, because healthcare is the one place where the actual consumer is not heard sufficiently.
Yeah.
The actual consumer being the patient. It is the drug companies and the hospitals who decide the protocols.
Yeah.
The government comes in over there. So the patient's voice also needs to be added when deciding what are the standard protocols, what is the affordability of them, and make people accountable for what they are saying. Because it's no use just talking in the air.
Right.
Yeah. My area of work and expertise, if you will, is in preventive care. And I really believe that if we can just expand that to go across the country, we would be dealing with half the disease that is there. When people know something about what they are suffering, if they can identify in the doctor's words or in anybody's words what these signs and symptoms mean, they will come earlier to the hospitals or to the treatment centers. We deal with awareness, we deal with prevention, and we deal also very importantly with supporting early diagnostic treatment. When they go to the hospitals, and as Sushma ji said, they're told have an MRI, have a CAT scan, and so on. They go to a diagnostic center, and the price of those tests frightens them away. They just go back home. So that is where we try to step in, because I think the money that we spend on early diagnosis saves everybody, the patient, the hospital, and us, vast sums more if the diagnosis is correct and if the patient goes to the right place for treatment.
Yeah.
A second point that nobody has raised thus far, and which I would like to raise here, why are we not making cancer a notifiable disease? It is notifiable in about 8 or 9 states in this country.
Yeah.
But even there, it is very patchy and it is not really pursued. Yet we have the experience when polio was notifiable, when HIV was notifiable, and we have the results in front of us as to how successfully we dealt with those diseases. Why not with cancer, which is far more rampant, which reaches out right across the country? If we can make this a notifiable disease, then we get the correct statistics.
Right.
We get the right, that those statistics enable us to build the resources that we need. and then to address the problem.
Thank you so much, ma'am. It was heartening to, first of all, hear, your side, and the kind of world that you represent. And I think you've raised some of the most pertinent points from patient's perspective. And your last point, which is about making cancer a notifiable disease. Yes, I think we have talked about that particular point at various forums, but however, somehow that has not been like a priority conversation. And I think I would circle back to many of you today that why don't we actually talk about that? But before we go on to that conversation, I would like to move on to Miss Anu Acharya, because just adding on Miss Anu on the same conversation that we're having, and and building it further from your expertise, what role do you think digital health technology can play in advancing the equitable cancer care? Because here we are talking about inequities which are prevailing, and they continue to grow. It is despite the fact that India is one country where cost of healthcare is less. It's sort of a destination. However, it is still inaccessible to the larger population. In our country itself. So, how do you think we can build or use digital health technology further and better to bridge those gaps? And what is the connecting link here? Over to you.
Thank you, Dr. Nalini. And I think, while some of the points, I think I agree with a lot of the panelists over here. And I think Dr. Jyotsna brought up the whole concept of prevention. And I think that's one of the areas that we are working on quite considerably. And I think, if you simplify this, that, you have 100 rupees to spend in cancer, I think 70 is being spent by the customer, but there's sufficient, but if they spend 1 rupee on prevention, they'll be spending 100 on actual treatment. So I think that concept, needs to be explained to, everybody, that, there is the communication aspect of it, which I think also was brought about. But the second thing, I think, which also many people mentioned, which was about protocols, is that cancer is a constantly evolving subject. So you're not going to have a standardized protocol for a very long period of time, but I think at least it can be something that you can base off and have a constant evolution of the protocol. So have one website that will sort of create a place to aggregate and there where everyone takes, and that should be something that should be there on the prescription. I don't know if it is a possibility. That's something that doctors can. But when it comes to digital, and one of the things that maybe should be done as a base level understanding of what risks are there in the population could be that when we are collecting data, whether it is for a census or for anything else, why can't we take a family history of our population? I think that will sort of give a fairly nice idea of where we have certain risk, and then make sure that we can actually communicate to those people at risk about early symptoms and things like that, so that they are aware of that. So I think the use of apps, whether it's the Prime Minister's app or whether it is any other thing, could be used for actually telling the end customers about or our citizens about the value of what you can do with understanding of symptoms and how do you get to an early preventive test and so on. The other thing that you can do with digital could also be that, other than communicating, I think can also be the fact that you can now have many things that you can do by sitting at home. And for instance, whether it is getting a DNA test, whether it's getting a blood test, whether it's actually getting the entire process, I think that's another thing that a lot of patients are not aware of. And I think that communication of these things happening, because a lot of people might probably not be mobile enough to be able to go. That could be another thing. And the third could be that, when we look at teleconsulting and a lot of matters where there, when we do, for instance, when we are telling people about the early risks, when you look at it from a genomic perspective, I think many times the first time when our genetic counselors or our doctors are talking to these patients is the first time they've actually spoken to somebody about in detail about their health. And I think a lot of times what happens is, and I go back to when I was a child, I remember, for instance, when I couldn't see the blackboard, I didn't bother about it. Until at some point I was forced to know about it, right? So I think it's the same thing with a lot of diseases, especially cancer, because it's sort of hidden and you don't know until someone tells you. So I think that counseling, that creating of that network is an extremely important aspect of that. So I think I can go on, but I know that there are many others on the panel, so I'll stop.
No, thank you so much, Ms. Anu. And I think Jyotsna ma'am and you have rightly brought to the fore the idea of preventive care and prevention when it comes to cancer, because there's a lot of looming fear of cancer, while people want to know, but they do not want to know. That's the situation when it comes to cancer. And I think that's where prevention comes into play. And I think prevention, like you said, that, we need cost effective ways, because while we keep talking about that, cancer care has issues, be it access, be it, cost issues, but if we from the beginning itself starts, building more conversations about prevention, I think we may not even, in future have to worry about many other things that we worry about today. And again, prevention, the idea is not only about building awareness, it is also about creating tools where we have more data when it comes to family history and family data, because those are also very critical components when it comes to preventive side of the spectrum of cancer care. So taking this conversation, I will circle back to Mr. Modi, Mr. Somal Modi. What do you think? We like representing the industry. How do you think we can build further on the concept of preventive care when it comes to cancer? Because that's one of the critical conversation. However, we seem to miss out that link more often than not.
Yeah, no, I think a very, very important point around the preventive cancer part. And I mean, if I could just throw up a statistic here as well, that if you look at the digital penetration in the country, right? So only 3% of the households today would have a computer at home, but at least 69% have a mobile phone at home. So I think one of the critical areas that we could look at is how do we really leverage digital as we move ahead in terms of the preventive care aspect as well, because that could be really leveraged. Now in 2020, government has also passed a resolution that telemedicine, the whole law around it, so that's also not a concern. So if we really leverage the digital technology that's available, which could be used to educate people, and as I said earlier also, whether at a CHC or a PHC level, or even if it goes down to our ASHA worker levels, that this is how you screen for breast cancer, or this is how you screen for cervical cancer. So if we can really leverage digital, it's going to be next to impossible to call people together and do this program. But now today, with the help of technology, I think this is something which is much doable. But again, here everything boils down to the intent at the end of the day, right? So I mean, if we pick up certain states, and given the geography that we have, even if every 4 or 5 stakeholders come together and they pick up one state and they say, okay, here we are going to go after this, let's see the results, how they come. But again, it is at the end of the day, whether it's a company, whether it's an NGO, whether it's a healthcare provider, it's boiled down to their intent, whether they really want to do it or not.
Yeah.
And if that willingness to do is there, I'm sure the means will come, whether it is digital technology we want to take, whether it is some other route we want to take, it's all doable at the end of the day. And we've seen it happening more in sickle, so a reason to believe that it can happen in cancer as well. Absolutely no worries.
Absolutely, absolutely. Thank you so much for making that point, Mr. Modi. And I think we have Mr. Maulik here with us. He would be leaving, I think in another few minutes. So, Mr. Maulik, you've heard the larger conversation today. So, if you could please, leave us with your, key remarks or some concluding remarks, or something that you would want the extended panel to also talk about today.
I think so. What Dr. Rajagopalan said earlier, right? How we can exactly do it? We have got pockets of excellence in various things, right? How those pockets of excellence, whether it's early diagnostics or let's say bringing patient groups together, right? We have got those examples out there. How we bring those examples as a package, and how the package could be then sustained over a period of time, because as sustainability is a big area of concern. Things change, people change, everything gets reinvented. And so how we can redo it once again, but appreciating that each and every colleague and each and every organization has a role to play. And if we don't come together, I think so after a couple of years, we'll be still having the same conversation. Thank you.
Right. Absolutely. Thank you. Thank you so much, Mr. Maulik, for your remarks. And
my apologies to have to leave.
Sorry?
My apologies that I have to leave.
No, absolutely no, absolutely not. I think it was a pleasure to have you here on the panel today. Thank you so much. So I'll circle back to Dr. Sushma, Dr. Somesh, and Dr. Shibu right now, because we have been talking about preventive care and the access to care to patients, but we cannot also forget right now that we have just seen or we are in middle of a pandemic, and this situation is just evolving with and we know that like how the situation might even unfold in the near future. So given that, cancer care has also seen a tremendous shift, in the middle of the pandemic, and and henceforth, so therefore we will have to maybe redesign and reshape our solutions. So in last 2-3 years, what has been the experience of cancer care? Because ma'am, you have been there in hospital, seeing patients and evolving, and maybe building newer or immediate imperative solutions, when the patients came to you in middle of a pandemic. And so what was the situation, and what do you think, what could be the plausible solutions for us, having in mind that this is also a new world that we are talking about?
So, Nalini, as far as cancer is concerned, I think what I can see, because I am also the chairperson of COVID task force, that people, those who are dying with COVID are less than the people, those who are dying with cancer in these days, because they are really, because of the pandemic, they have really suffered a lot, because all our services, we have shifted, everybody is worried about it's important to take care of the pandemic, but it's also important to take care of cancer patient equally well. So uh, I don't know what is the solution right now, but I can say this much, that cancer patient should have not been suffered, because we have seen our, and which we have published in the one of the world clinical oncology, that 600 patients we have interviewed, and we have shown in that paper that the way they have suffered in terms of their treatment, means like if they were in the investigating stage, stopped. If they were in the treatment stage, it has stopped. Their surgery was planned and surgery was postponed. And by the time pandemic first wave was over, second wave was over, it was inoperable. And once it is inoperable, then there is a palliative chemo or palliative radiotherapy. And and as far as the palliative medicine is concerned, like people are suffering in pain, and although telemedicine, we have tried our level best that we can provide as much as possible care or advice through telemedicine, but again the medication is available only at the certain places. So as for a major time period, there was a stop, completely transport was also stopped. It was such a huge problem. If a patient who is in the village wants to procure opioids for cancer pain management, he knows that this patient is going to die. It was a huge problem. So we have evolved with so many strategies, that we used to give medication for 1 month. We used to try that they should go to the nearby area and they should procure medication. There were a lot of solutions we tried. So telemedicine was one was the important solution. I remember I have given almost end of life care counseling, so almost 15 to 20 patients in the COVID wave 2 and even in the COVID wave 3. So video consultation or telemedicine was very important way. Giving them a possible solution nearby area was another way, but it was cancer was badly hit because of the pandemic, and probably they were not getting the treatment as they should have got in the right time. I think everybody, when we see by the time the COVID wave 2 was over, and I used to see those patients whom I have already planned for, they were already planned for surgery. Now they are coming with the huge growth, and they are in the last stage of the disease. So this was I don't know what relatives and what patient must be thinking about this. So there should have been some, I don't know what is the solution, but it was a problem. And cancer patients was, I think not only cancer, I think all non-communicable disease patients are badly hit. And as far as cancer wave 3 is concerned, patients are not dying because of COVID, they are dying because of the comorbidities, because comorbidities are not getting treated properly because of the fear.
Right. Thank you so much, ma'am. And like we really hear you. And Dr. Somesh, Dr. Shibu, ma'am has, I think very nicely elucidated that the disruptions, that took place, we heard about them, and across the value system, be it screening, be it, treatment, be it access, all the entire components again on this value chain of cancer care, there were severe disruptions. And the unit which suffered the most is maybe, the cancer patients, right? And we have seen there were patients where the situation aggravated to a much, severe extent. And also from the intervention perspective, like, if you can add upon to ma'am said that, there are problems that she may not, think through what could be the solutions while they did, yes, ma'am.
Then I just want to add one more thing, that as far as if I consider, if I see if I go in the past and I see that, for example, my cancer center IRCH, even during the peak pandemic, all oncologists used to sit with all sorts of cap, mask, gown, face shield, and they used to try to see as many patients as possible. But when transport is disrupted, they can't do anything. Patients are not coming because of the fear, they can't do. But they all oncologists, they were trying their best that patients should not suffer, but still this many patients has. Yes. Sorry.
So just hearing what ma'am is saying, that there is one side, the one side of the spectrum where somebody is ready to provide the services. There is all expertise, there's all knowledge available. There's another side, patients who need it, they are also there. But there are gaps because there's disruptions. There are services which have been disrupted. And we have, a person from industry, we have, stakeholders and representatives from the programmatic intervention side. And how do you think, in your, from your knowledge, what do you think? Because these situations have not ended, and this will keep on continuing, because if we don't build or institutionalize certain practices. What do you think, Dr. Somesh? We will start with you, but because this is a very grave problem here,
See, cancer, in the best of the times, we are unable to, ensure universal availability of care, timely and appropriate and adequate care. So it's pretty, obvious that in times of acute disruption, when even a vaccination service was disrupted, cancer was completely, I knew this. I was in US. The same thing was happening in US for cancer care. No surgeries were planned. The planned surgeries were postponed, and all these tragic stories that we are listening happened across the world. So that's one end of the spectrum, right? But I think to address some of these barriers to care in the best of the times, and as well as in some exigencies or some emergencies, I think we need to come up with we need to go back to the conversation we started. We need to go back to the cross-sectoral collaboration that we were talking about, right? Because this is a problem that cannot be solved by just medical care and healthcare providers of the hospitals, because they want to take care. Ma'am talked about people wanting to take care, but transport is not happening. So how do you have that? So, for example, in maternal health, that was also disrupted, but what came back was cesarean sections were starting, right? It started as soon as some disruptions were lifted. Why was the cancer care not being initiated at that time? So obviously, the priority of how the stakeholders prioritize cancer care is important. I want to take us back for a moment, to Shibu's comment earlier, and I think for making anything more resilient, right? Any service more resilient, you need to use innovations and technologies to leapfrog some of the system dependencies. And I'm talking about more foundational things here. And so for that, so today, for example, we are seeing early diagnosis being an issue. It's still only 20% of women get a diagnosis done, even after a positive CBE. Even in the best of programming, we saw, almost 40% women falling out of the care pathway, even after some repeated reminders, after she was diagnosed with a CBE positive at a primary care level. So we need to, why was that? So again, because that woman needed to come to the tertiary care institution again and again, and some is, indirect costs. So for that, we need to take care closer to them. Again, decentralizing services, taking it closer to the community so that, And again, the partnership with private sector, the Shibus has said, is critical to do that. Private sector, not only in terms of the providers, private sector in terms of entrepreneurs, who design solutions to help these. It's happening already for other diseases. Why not here? Partnerships with the transport associations. Cancer, if it is for maternal health, in Bangladesh, if there is a woman who is pregnant, she has a flag on her house in a village, and everybody knows that woman is pregnant. So in an emergency, the whole village takes care of her. So that's where you bring. That is how you think through innovations, where tech or non-tech innovations, to make these services more resilient to these exigencies. And those partnerships have to be evolved. My simple suggestion, this is a very complex thing that we cannot solve, and it needs a lot of co-designing solutions, and we can't solve that everything here. But for now, for me, one or two things that we need to do right away is understand, what are those parts of the care pathway that can at least be made more resilient. Early diagnosis part is one such. Palliative care, or even continuity of care, maintenance therapy. If we identify even the lower hanging fruits and make innovations through tech or non-tech, even like task sharing, etc., and try to make it, much more less dependent on the upper levels of the health system, that will make the services more resilient.
Absolutely. Thank you so much, Dr. Sumesh, for your remarks. And moving on to Dr. Shibu and Mr. Somal Modi, because adding on to what we have just heard from Dr. Sushma and from Dr. Sumesh, that, we are talking about defragmentation, we are talking about decentralization, but not only in the context when it's a normal situation, it is also in a context when the services are disrupted. A lot of, global disruptions are taking place in the health systems, and, overall systemic, aspects of, the economy, or, whatever we have seen so far. How do we build, use the knowledge which is available to us, by forging partnerships and collaborations, and how do we do it? And a very naive question would be that, who is going to do it? How do we institutionalize that? I mean, that's a naive. I know that there's like, with a pinch of salt, I'm asking this question, but who does this?
We do.
Absolutely, ma'am.
Yeah, so to answer that question, so I think digital and decentralization has been discussed here, and that remains as is. I would say that when you look at the government of India's focus on primary healthcare, so the health and wellness centers, and the investments actually planned, at least planned, and then the targets for, establishing that, operationalizing the health and wellness centers and the digital health investment. We need to actually see in this, little bit optimistic about that, whether that will happen, and then this is an opportunity and a forepush for that, because we have 3 major cancers actually embedded and notified as screening, opportunity for screening in the health and wellness center. And there is a 15 Finance Commission investment scheduled it happened from last year onwards, and 900 crores has been spent, essentially focusing on diagnostic, and that diagnostic is actually decentralized to district level, then starting from the health and wellness centers to get pivot at the district level as a center of excellence. So these are opportunities where we can now think about how can, as partners, like, okay, there are digital partners here, there are implementation partners like that, bring in technology partners like startups who work on the tools which enable decentralized cancer care. AI partners, there is a whole lot of AI focus on this digital health. So I think these are, so just pivot your, focus around the PSC thing, because that's a simple most thing, I would say, because you target 3 critical cancers there. Right. And if you empower the peripheral health worker or the system and make it owned by the local self-government, it's their damn business. It's not the business of Prime Minister Modi to come and take care of the population over there. Yeah. So if you create that system there and locally owned with simple tools which can enable, and which also connect with because we mentioned about, Mr. Modi mentioned about the connectivity, the scope of it, Anu mentioned about the digital tools available. So these are something which, like, let's focus on empowering the decentralized system for it. And then you build on it. I'm just saying there are investment focus and money has been parked, and they're probably what they don't know is that these knowledges. So let's, as a group, probably bring together all these things. Let's have convenings with all these skill sets and help selected governments as a group and say, this is how you can define your roadmap. These are the tools which is complying with your systems, which will help optimize your human resources, not overburden. And this is, and again, on the top of it, you actually define SOPs and guidance document at what level, who will own it. And then again, it will be easy. So then come the cost share of what percentage of it is actually center share versus the local self-government share. So I think that's how I see this as an opportunity to revisit to that conversation and rethink about it, because COVID actually helped us in decentralizing the diagnostics. I'm not talking about the infectious disease is the focus right now, but again, that I mean, including sequencing, right? If you want to actually further go into the molecular level diagnosis or genotyping stuff, and this is the right time to think about it.
Absolutely. Thank you so much for your remarks, Dr. Shibu. And Mr. Modi, over to you. Same question, but from industry perspective.
Yeah, I think from an industry perspective, one of the learnings over the period of time, right? So if you look at the various states in the country as well, I mean, there are certain states who are far ahead of, say, a West Bengal or a Kerala, far ahead of the other states when it comes to providing healthcare. We never knew till recently that below poverty line is covered everywhere, right? We will have your state schemes, you'll have your Ayushman Bharat, a lot of other things. But West Bengal also covers their entire population through different schemes. So, you know, such states where they've taken health as a priority, I mean, if we run pilots there, I mean, as an organization, we can, you know, look at how do we create that ecosystem. So it's a question of bringing all the stakeholders together, and that's a commitment where we can be a pivot, where we try to get everyone together, select a few districts, create a model which seems this is working, and then how we extrapolate it at other places. So as all the speakers said earlier, there are best practices available in the country. There are enough and more things that can be implemented, digital, non-digital way, the way we want to implement it. But it's a question of taking a lead, selecting a few places. Someone has to own it, right? At the end of the day, someone has to own it. And you'll have a lot of people who will come and partner along with you. So if, I mean, as a company, if we can do it like we've started working in Orissa or in Sikkim and things like that, if we can own a few districts, we start off creating that entire infrastructure there, then it is plug and play, right? So there, if early detection can be worked, and if that model is successful, in fact, today in cancer care in 5 or 6 states, I know for a fact in Madhya Pradesh, they've taken chemotherapy administration even to tier 2s and tier 3s as well, which was not the case earlier, by training the doctors there. So, you know, this was self-initiation by one physician who really decided to go and do it. But these are models which are available. It's a question of someone taking a lead, creating an ecosystem, and then extrapolating it to other parts of the country as well.
Absolutely. Thank you so much for your remarks.
Nalini, just to add to this, Swamil's point and Shibu's point, the good news is we have started things, right? So just on the decentralizing diagnostics, we are partnering with Novartis, Swamil's team, and we are in Odisha. Exactly, we are taking diagnostics to the district hospital level, you know. We are partnering in some other, you know, I will not name the company, but with private, you know, entrepreneurs to take AI-based point of care, you know, screening devices for cervical cancer to the health and wellness center. So those green shoots are also happening. So there is hope there. We just need to, you know, amplify, accelerate, and really have some speed and intensity more into it. And I think resources are the one big constraint that we all know in this space that we all have to work towards generating. Over.
Absolutely. And thank you, Dr. Somesh, for adding that, because I think towards the beginning of our conversation, actually, I think Mr. Maulik talked about, you know, knowledge creation, but also, you know, using that knowledge and upscaling it for wider use. And I think this was an apt example of that. And circling back to Jyotsna, ma'am, you rightly, you know, intervene and said that it is us, because I think civil society, patient support groups is one of the most integral component of the entire ecosystem that we are talking about today. And that particular stakeholder group has actually brought, you know, focus on many areas that has actually been neglected so far. And it has actually given a lot of solutions as well. So again, you know, circling back to the same conversation that, you know, we are not talking about times which are normal, but also those times when the services are disrupted, where patients need extra support and extra hand holding maybe? And what was your experience during COVID? I'm sure you must have worked with more closely with the patient support groups and more patients. And what do you think? What is a way forward in your opinion there?
Nalini, thank you. That's an important question. We blame COVID for a lot of things, but we have not recognized that COVID has made us think out of the box.
Absolutely.
We have gone the virtual route. Now, I don't think any of us dreamt that we would be doing Zoom meetings, Zoom training, Zoom concerts, all this in the space of 2 years.
Right.
The schools, children are learning with mobile phones. Their teachers are giving them information over the phone. Why are we adults falling behind? We at Indian Cancer Society have used technology in a couple of ways, and I'll quickly enumerate them. We have a mobile app for women in English and in Hindi, and it is for breast and cervical cancer. It's called M-Shakti. It is free to the user, and it is available on Google Store. It's a popular app. Women can watch it in their own time. The other thing that we have done is put a course of cancer fundamentals on the Government of India's Swayam platform. It's a self-learning platform. Again, it is free to the user. And it is available across the country. We started in English, and that became very popular in the south and east of the country. Then we added another component that we call e-Chaitanya, and that is in Hindi, available for the Hindi belt. We are in the process of adding Punjabi, and God willing, other regional languages. So you can sit at home and access this and find out anything you want about cancer. We use the virtual platform as a counseling platform. If anyone is interested, every other Wednesday, our rehab center invites doctors, invites counselors, invites experts in different fields to talk about the issues that are of importance to patients. I said right at the beginning that cancer does not start or stop in a hospital. After their treatment is over, there's a long road to travel. They want to know what to do to stay healthy, what foods they should eat, what they should do, how can they calm their mind, how can they sleep better. All these are issues which are not too small for us. We address them.
Yeah. Absolutely. Thank you so much for giving that example, because a while ago, Dr. Shibu also said that, we cannot just really wait for the government to bring in the interventions. And yes, COVID has given us, it was a huge disruption, and it was also a time for us to think out of the box. We have really done that. And I think it's just now a matter of time that how do we sort of, stop working in silos, institutionalize whatever, we have built upon so far, and share that knowledge with each other so that knowledge can grow further from there. Ms. Anu, putting that same question to you, because Jyotsna ma'am, actually talked about how did they facilitate, that the interventions of technology. How do we grow further from there? And do we wait for the government to institutionalize more regulations around it? Or, what is the other way around it?
If we all went to an outcome-based thing on saying how many can we keep healthy rather than how many have we treated, I think our concept of towards cancer and others would or any other disease would change. So maybe what we can do as an experiment could be that, let's say we take 2 villages and you track those villages over a period of time. You get the government involved. You get companies like us to do the initial genetic screening or things like that. You get other statistics to track what is happening with them and see what happens over a period of time. That if you did an early intervention, did that make a difference? Did the standardized protocol make a difference? And I think if we can create the right kind of measures, I think we'll be able to do this. Second thing I wanted to say is that a lot of new advances have come in genomics, in the way that you treat cancer, right? And a lot of times because of affordability issues, a lot of that is not being able to, they are not coming to India for reasons. So if you're looking at things like pharmacogenomics and others that are helping you to treat, I think if we focus on the 90% that you can treat in the early stage and then only a 10% at a later stage, I think we'll be able to fund all of those in a much better way if we can get everybody's thoughts together to be able to save them. So I think the thought of keeping the country safe, or not safe, but to be able to manage to treat should be spend more time, 90% on prevention, 10% on treatment. I think we'll be able to tackle it if we all have the same thought process. So that's what I'd like to know.
Absolutely. Thank you so much, Ms. Anu. And while we have positive time, because our next panel is about to start, last comments from Mr. Somil after hearing all of our stakeholders, where do you think, we move forward now?
Nalini, I have a question when you have a moment.
Yes, absolutely, ma'am. I'll circle back to you then after Mr. Somil's comment.
Okay. No, actually, Nalini, would add to what Jyotsna ma'am said, right? And COVID actually surprised us more than anything. It's not about only treatment, but how we handhold the patient in the entire journey. And we did some pilots with a few hospitals like Tata Hospital and all. And, on a fixed day at a fixed time, we would invite all the patients to come for a counseling session. And to our surprise, we had patients dialing in from Bihar, Uttar Pradesh, everywhere to attend a Zoom session. Now, our thought was that we may have a few from Mumbai or, one or two metros. We didn't expect the penetration to be so high. And we've done it very successfully. And the feedback we get is when we go to the hospital, हम डॉक्टर साहब के साथ इतना टाइम स्पेंड नहीं कर पाते, पर ये 45 मिनट्स में whatever doubts we had, everything doctor addressed. So the adoption of technology is very good. On a sickle part, something we've done is in around 9 states we run programs called Sat Sat. So on the 7th of every month at 7 p.m. in the evening, doctors and patients dial in onto a link, and then they exchange views, their questions, queries. So this is working very well. I think it's just a question of setting it up, having people who will drive it, and then it just takes on from there. I mean, if the content is really good, it just takes on from there.
Right. Thank you so much actually for adding that, because that's a real manifestation of a multi-sectoral or cross-sectoral partnership, Ma'am, over to you.
My question was to Saumil. If I may ask you, please. Saumil, you said that at some conference in the United States, Tata Memorial presented a paper on how they used VIA, I think it was, for screening women for cervical cancer, and everybody applauded them. Now, to my knowledge, which admittedly is very limited, can you please tell me, I am told that the gold standard is the pap smear and the HPV DNA test. So what were they applauding?
Ma'am, you are right. The gold standard is this, but the initial screening which was done, because see, everyone today, if you go, would not afford a pap smear or an HPV or things like that. This was, I'm talking almost, if not less, around 10 or 12 years back, which paper was presented. And I can send across this paper to you. This was in a community. They had done a complete screening program with very low cost effective techniques to identify early cervical cancer. So maybe I can send you the details, but you are right. Over a period of time, it's pap smear, it's other technologies that have come in, but they had actually used a very low cost to screen the whole population for cervical cancer. So maybe I can send that across to you, ma'am.
Please. Thank you.
Thank you so much to everyone. So while we have sort of overshot our today's time, but it was a very, it was really an insightful session. And I think a session which resided on a lot of hope that this is not the end, this is rather the beginning. And I think I look forward to, for more and more conversations in the future, and maybe more interventions in the near future to actually the silos that we talked about, how can we sort of bridge all of that. So thank you so much for joining us today, and thank you for all the work that all of you in your individual and collective capacity have been doing, to make certain, remarkable change in the space of cancer. Thank you so much to all of you. And I hand over now to Anisha to begin the next session for today. Thank you so much.
Bye.
Thank you.
Bye-bye.
Thank you, Dr. Nalini, for taking us through this very insightful session. Now, all day we have been spending talking about cancer, and it is our sincere hope that all this conversation will lead to greater awareness, and this will help tackle cancer more fastidiously in our country, where we see early detection and better outcomes of cancer treatment. Now, what I'd like to bring to your notice is that in this session, we are going to turn the spotlight on the global movement for women's cancer. And this is, of course, part of the third Cancer Summit organized by the IHW Council. Around the world, cancer affects more men than women. However, the trend is reversed in India. We see more women reporting cancer than men. But there is a silver lining here. The mortality rate amongst women is lower than men. So that may be explained by the fact that women are generally more exposed to medical checkups than men on account of pregnancy, childbearing, child rearing. So women are able to report abnormalities they feel with their physician when they meet them. Breast cancer, ovarian, and uterine cancer account for more than 70% of the cancers in women in India. And if caught early, also allows for a higher chance of survival on treatment. So this session, I'm going to have a fireside chat with two esteemed guests, and we're going to talk about the strategies of tackling cancer amongst women in India. Please welcome Dr. Shalini Singh, Director, National Institute of Cancer Prevention and Research, ICMR, and Dr. Gaurav Agarwal, Professor, Department of Endocrine and Breast Surgery, Chief Medical Superintendent, SGPGIMS, Lucknow. A warm welcome to both of you. Thank you so much for joining us.
It's a pleasure being here.
Shalini ma'am, let me begin with you. Is it true, Anisha? Is it true that the number of new cases of cancer reported in India are more in women than in men?
So, as the statistics of 2020, the global cancer statistics, so in women, we have about 6.8 or something lakh cancer cases, and a total of about 13 lakh new cancer cases are there in India, reported in India. So it's, I mean, we should not go into the nitty-gritties, but they are quite similar, I would say. Not too much of a difference because,
okay,
yeah, that's what the report says.
But women, they say women are stronger, they multitask, and they're so good at everything. Is it true that women also beat cancer better in our country, Shalini ma'am?
No, you can't say that the women beat cancer. It depends upon the care that they get, what time, you know, what stage they're detected. So it's not the a biological sex that determines their outcome.
Right. Dr. Agarwal, what have you seen in your practice? They say that more men get cancer around the world because of their lifestyle. You know, they smoke and they may be exposed to industrial occupational hazards more than women. So worldwide, more men are affected from cancer than women. What has been your experience in India? And how do you see them tackling the disease as well? Because you will go to a doctor during your childbearing years, during pregnancy, or for children's vaccination. Your interface with the medical community maybe a little more than men. So does that make it easier for women to get their concerns across?
Well, as far as my own experience goes, it's I would say a very limited experience, because as a subspecialist specializing in breast cancer and endocrine cancers, I do not see a whole bunch of other cancers. But going by the literature and general awareness about the disease patterns in India, well, yes, the total number of cancers detected in women is women that slightly outnumbers the men. But then, as Dr. Shalini Singh said, I don't see any definite pattern there. I cannot, certainly not point out a biological reason why women should have more cancers in our country, especially when the numbers are slightly on the lower side, overall population-wise. Coming on to the other part that you said, that what is my perception of why women are detected to be having cancers, or why do they detect cancers in themselves? To some extent, it is the kind of or nature of cancers or the origin of cancers in women compared to those in men. To a large extent, when we talk of cancers in women, as you said in the opening remarks, it is breast, cervical, endometrial, and ovarian cancers, all of which have clear manifestations. They do manifest with symptoms which are detected or picked up by women themselves rather easily. In comparison, quite a few of such cancers which affect men, including lung cancers and prostatic cancers, and a few others, which do not result in clear manifestations until very late. So perhaps that is one of the reasons why women detect their cancers more often or rather quickly as compared to men. The fact that women do undergo numerous medical tests during their child rearing age, during pregnancy and during while they are nursing a child, perhaps has little to do with this, because these are not the age groups where we see a lot of cancers in women, with the exception of cervical cancer, which may start as early as in the mid-30s or early 30s. But other cancers which we usually see in women, they are mostly cancers of middle age and elderly age.
Shalini ma'am, would you like to share some data regarding the most prevalent cancers in India? Like Dr. Agarwal mentioned, like I said, it is basically the reproductive cancers that afflict Indian women the most: breast, cervix, ovarian, and endometrial cancers. So would you share some data? And, does this mean that the messaging about cancer awareness towards women has to be different?
Yeah. So in India, the breast cancer forms the largest number of cases as of now. Earlier, it was the uterine cervix, which was the highest, had the highest number. Now, nearly 26% of cancers in the women are breast cancers. And the cervical uterus has gone down. It's about 18% of.
All right, please go ahead.
Yeah. So, and then next comes the ovarian cancer, which is about 6 to 7%. So these are the figures.
Ma'am, any data or explanation on why there has been a shift? In about a decade or so, we've seen a shift from the prevalence of cervical cancer being the largest in India amongst women to breast cancer. What has worked? Because both of these are screenable cancers, but something seems to be working to reduce, the incidence of cervical cancer. Any evidence or any data that we have here?
Yeah, so we have the National Cancer Registry, and our institute in Bangalore does the population-based cancer registry, and they collect data on the hospital-based cancer registries. And we have these population-based cancer registries in about more than 30 places. And what they have seen is that over the period of time, the breast cancer cases have risen, and the cervical cancer cases have come down marginally, but the breast cancer cases have risen actually. So this is more in the urban and the metros. The breast cancer cases have risen. And there are on the report shows a lot of graphs about that, how they are intersecting at various time points, and at which time point the breast cancer took over the cervical cancer, and so on and so forth. But in the rural areas, there's one population-based registry in Barshi, where it is a rural registry, where they have not seen this drastic change between cervical cancer and breast cancer so far. But yes, breast cancer is rising in every registry.
Dr. Agarwal, what do you think is at play here? What is leading to an increase in the incidence of breast cancer in India? And why I ask this is because on average in the West, breast cancer is diagnosed at around 60, which is the median age at which breast cancer is detected in the developed countries. In India, it's 45 to 50 years, and very aggressive forms of breast cancer like the triple negative breast cancer are seen in even younger women in their 30s. So what's at play here? What's happening? Why is the incidence of breast cancer going up in our country?
Okay, so it's a combination of many things. Certainly, we are detecting many more cancers now as compared to what we were doing a few years ago, or maybe a decade ago, or more than a decade ago. But simultaneously, there is a true rise in incidence of breast cancer. There are a number of factors which may be at play here. One of them is the changing lifestyles of our population. The number of children in Indian society, that's coming down. Women are either not having many children or are having their first child birth after, say, age of 30 years, and that's a definite risk factor. Reduction in the child in breastfeeding, that's another factor which may be playing a role here. All kinds of carcinogens in the environment, in our diet, and the nature of diet that we consume, those are contributing to rising cancer incidence in general and increasing incidence of breast cancer in particular. And when we compare the incidence of breast cancer with cervical cancer, which used to be the commonest cancer in women until, say, a decade ago or 15 years ago, the story is actually, I would say, a success story of improving menstrual hygiene and postpartum and reduction of postpartum infections. Mind you, cervical cancer is primarily a disease driven by or initiated by human papillomavirus.
Yes.
And with improving menstrual hygiene and personal hygiene in women, especially reduction in postpartum sepsis, with increased number or great proportions of institutional deliveries, that is something which has been taken care of to a large extent. And certainly reduction in cervical cancers, the incidence and the total number, absolute numbers, is a success story of public health system in country. Simultaneously, the incidence of breast cancer has been rising. So it's not surprising that we have seen a reversal of proportions of breast and cervical cancer. Even in the rural registries and semi-urban registries, we now have lower number of cervical cancers as compared to breast cancer.
Right. Shalini ma'am, a number of points have been raised by Dr. Agarwal, saying that if you would be breastfeeding your children longer, if you had your babies earlier, your risk would be reduced. Now, so when we try to create awareness amongst women about these cancers, should we also tell them about things they can do to reduce their risk? And when we do this messaging, one part of messaging is addressing the end person, the woman here, breastfeed more, have your babies early, have a good lifestyle and a good diet and exercise. What about some messaging that is to come from the government side about screening, about pap smears, and maybe even including the HPV vaccine as part of the free vaccination program in our country? Do you think that these can be actionable ideas going ahead?
Yes. See, as Dr. Agarwal also pointed out about the factors which lead to breast cancer, they are mostly, I would say, the metabolic risk factors, which change the hormonal milieu, and then they lead to cancer. So certainly, as far as breast cancer goes, we need to point out what are the risk factors and what are the protective factors. So both kind of messaging should have been brought out, like you must maintain a healthy weight. Obesity and overweight is definitely linked to breast cancer. Use of alcohol, use of tobacco is certainly linked to breast cancer, and tobacco use is also linked to cervical cancer. So early menarche and late menopause. So early menarche happens when, the girls, they attain puberty early because of so many metabolic issues. They gain weight faster and they have this menarche earlier. So, and same goes for late menopause. So all these are endocrine and metabolically factors which affect the breast cancer. Diabetes is another thing which is very important, and this certainly leads to higher incidence of breast cancer. So these are the things which these are the risk factors which we can stay away from. What are the protective factors? Being physically active has actually been shown to be protective against breast cancer. Breastfeeding your child, and of course, eating plenty of fruits and vegetables, that goes for any cancer, including breast cancer. So this is the kind of messaging which should go around.
And the efforts from the side of the government when it comes to screening either for breast cancer or for including the HPV vaccine as part of the vaccination given to kids as a mandatory thing in our country, do we need to have that as well?
So the government first needs to have also these messaging around risk factors and protective factors. Yes, whatever the policy of the government is around vaccination or screening, that certainly goes around, but these factors never come around. Like we have the population-based, the population-based cancer screening guidelines. So that messaging is coming across. So for instance, for cervical cancer, they are saying that you get yourself screened between ages of 30 and 65. Same goes for breast cancer, oral cancer.
But so ma'am, cervical pap smear is part of your screening should you go for an executive annual checkup. But a mammogram is not. So, at one stage, we are saying that screening is good, and these are the lifestyle factors that reduce your risk. But if, things get oiled in, like a screening is part of your annual checkup, then, a lot of issues get resolved.
Annual checkups are not necessarily meant for every year screening. It's in the case of cancers. It's there are different modalities the government uses to come to a conclusion as to what has to be given as a population-based. So we are talking about what the government is giving as a population-based cancer screening.
All right.
So it decides on various, the experts sitting there, then they decide what is the cost, how effective it is, and what is acceptable to people. So accordingly, they decide which method to go for.
Right. Dr. Agarwal, we have spoken to many oncologists and we run month-long campaigns on breast cancer awareness. We are told anecdotally from their experience, the doctors say that many women report late when it comes to breast cancer. If you're coming at stage 1, breast cancer has a very high cure rate. But, women are coming late. Some may feel a stigma, some may be fearful, and hence, delay diagnosis. Some may be completely unmindful, very young, and they don't expect it happening to them. In our country, are there genetic factors leading to breast cancer? Because, it is believed that breast cancer runs in families. So that's another reason, people don't want to talk about it. They feel there's a stigma attached to it. And hence the diagnosis is late and the treatment is prolonged. What have you seen in your experience?
Okay, so there are two parts to this whole issue. One is what proportion of all breast cancers in our country, in our society, actually have
genetic basis,
genetic kind of cancers. So from whichever data set we use, including my own experience, the proportion is no more than 5% of all breast cancers. So no more than 5% of all breast cancers treated in India can be linked to a specific genetic or familial pattern. But that doesn't mean that these 5% are such cancers which where there is a certain family history of the women of having breast cancers or various kind of cancers in numerous first degree blood relatives, or else there is a certain kind of genetic predisposition, a known genetic mutation which predisposes to breast cancer or perhaps breast and ovarian cancers. But it also may mean that there are a number of other so far undetected genetic forms which we do not recognize so far. So there is a possibility that there would be undetected genetic forms where further research and further recognition of these so far undetected cancers or genetic cancers may help in future. The other part that you talked about was the stage at diagnosis and what is causing cancers at a rather young age. Well, again, there are not, I cannot give you a definite answer to what is causing cancers in rather young age in Indian society, but there are a number of factors or number of predisposing factors which we know about. As a whole, our population is young. So we have what we say the population bias or the demographic bias. Because the entire population is young, the probability of younger people having diseases in general and cancers in particular would certainly be higher compared to a society or a population which is generally not so young. So that is a definite reason why we see quite a few cancers in early 40s to mid 40s in women. Besides, there may be other factors, both environmental factors, like it is suspected that the water table pollution or water table contamination has a role to play in causation of various cancers. In Gangetic Plains, gallbladder cancer is so prevalent because of the pesticides leaching into the water table.
But that should affect men and women alike, right? These are lifestyle issues.
Certainly. These are so there is no reason why we should differentiate between men and women as far as these carcinogens go. But when it comes to breast cancer, innately women are more prone to develop breast cancer. There's 100 times more possibility of a woman developing breast cancer compared to a man. So this very same carcinogens would affect women much more as compared to men, and that is why we see these cancers occurring. That's possibly one of the reasons why we see these cancers occurring at a rather younger age. But as I said in the very beginning, we cannot be certain as yet. There is only preliminary data available so far which points towards these.
Right. Shalini ma'am, what are actionable strategies that we can do right now?
Good afternoon. Good afternoon.
Good afternoon.
Good afternoon, Dr. Rath.
I would request
sorry.
Just
sorry.
Put yourself on mute. We'll come to you,
out.
Sir. Yeah, we'll come to you soon. Shalini ma'am, I was asking you, what are the actionable strategies, go-to strategies right now that we can do in our country for people, for NGOs, for support groups, and for the government to increase awareness about breast cancer, on how to reduce its risk, and have better screenings to catch it early?
So I would say in general, awareness or knowledge, especially in health education, is the key. So we shouldn't rush to go-to strategies. We have to take everything along. Otherwise, one thing gets left. But the first and foremost thing is awareness or knowledge, because knowledge helps us to understand things from multiple perspectives. It helps us to communicate with clarity, whatever our intention is. And then there are so many biases and myths and assumptions which are going around in the society. So it helps us to mitigate those. Then when a person has knowledge, it helps you to become better decision makers. And then you can influence whatever the situation you are in, you can influence those outcomes. You can have better outcomes for the same thing. And if
I'm aware, I
Yeah.
know, I'm not afraid. But where do I go for screening?
Yeah,
I live in a village and there's no access. How do I afford it? So these are also real issues that need to be addressed.
Yeah. So first thing is knowledge. But then you'll say, okay, I want to get myself screened. There are the whole NCT program is built around that structure. The ASHA workers are there, then the primary health center is there, and then the district hospital and the tertiary health center. Then there are regional cancer centers. So our district health system is built that way.
And so we need communication on how the system also works, right? So that people know what is to be done.
Yes,
right?
So all these methods are there for we are training ASHAs, we are training the nurses, we are training the medical officers, and we are training the gynecologists. So at our center, we have all these 4 programs running all the time through hybrid mode now because of the COVID, and earlier it was a hands-on training. So,
all right.
Yeah. So the government has made its operational guidelines for cancer screening, and all the states are adopting it one by one or whatever their strategy is.
All right. So the government is mindful of this problem of breast
Absolutely.
cancer amongst women and even cervical cancer, and has put in place modalities so that screening is proactive and cases are caught at the beginning stages. Dr. Agarwal, then one of the go-to strategies for everybody else, oncologists, of course, they will give the best advice possible once you reach them. But say physicians, the go-tos, if you have a problem, you go to a physician or ASHA workers or your family or your friends or NGOs. On one stage, you're saying, you're having lesser women are having lesser kids, they're having later marriages. They're doing this because they're career focused. The government says, Beti Badhao, Beti Bachao, you want your women, you want your girls to study hard, pursue a career, then childbearing gets delayed. How do we get around this? How do we increase this societal awareness that some things need to fall in place so that you reduce your risk of breast cancer? Dr. Agarwal, the question is for you. As a society, as NGOs, as support groups, how do we create an awareness about reduction of the risk associated with breast cancer and cervical cancers?
Well, there's no quick fix solution I can provide to you. It's a matter to be taken up by the country as a whole, the society, and let's not depend too much on the government for it.
No, this is not the government I'm talking about.
Yes.
Because for years now, women in our country are seen as the lesser sex. So now everybody's saying empowering them with education is important. Education then goes on to higher education, then goes on to career ambitions, and then childbearing, family become relegated, and nobody realizes that this ups your risk for breast cancer or cervical cancer.
But I certainly do
this?
agree with what you say. With changing lifestyles come various kinds of lifestyle diseases, and cancers are just one part of it. Various kinds of other lifestyle diseases are certainly a part of the same package. And so what is required is to create awareness about healthy lifestyles. Even though a woman or women in general are career oriented, driven to succeed in this competitive world, but simultaneously they need to be made aware of healthy lifestyle and what all things they should practice in order to reduce their lifetime risk of developing various diseases, including cancers. And awareness is the key. Awareness about what are the common disorders or common diseases, how one can pick them up, what are the warning signs, how can one participate in screening programs, what can you do to reduce your own risk of cancers. These are all part of awareness programs which are essential. Government is doing its bit. Non-governmental organizations are doing their bit. The professional societies are doing their bit. But it's a combination of all of these put together has led to somewhat better awareness today. And while we are still not there, while we continue to dabble with the problems of advanced stage cancers, still many women coming with third and fourth stage cancers for treatment. We do have somewhat better scenario today compared to what we had, say, a decade ago or 15 years ago. We now have more than 50% women being of a breast cancer being treated in stages 1 and 2, which are potentially curable stages, compared to, say, 1/3 about a decade ago or maybe 15 years ago.
So this is definitely working. The awareness, the
absolutely.
talking, the removal
there
of
is
stigma, it's all working.
It's all working for sure. It is working at a slow pace, slower than what I would like to like it to be. But there is certainly light at the end of this tunnel. So this is what we all need to continue working towards, and perhaps expect or try and increase the pace at which this messaging is taken across, and simultaneously, as you pointed out, create those systems where an aware person, aware woman would go to for screening herself or for getting attention for her concerns. So we need wellness centers more than we need hospitals. So that's the right.
And the government's effort is already underway to set up these wellness centers and to get their network for cancer care going. Like ma'am mentioned, tertiary hospitals, secondary hospitals, and then the super specialty hospitals in the cities. Let's hope that all the puzzle pieces fall into place soon, and we have a pace of awareness which is increased up to the liking of Dr. Agarwal, so that we will see cases of breast cancer being reported in the early stages where cure rate is high. I'd like to thank Dr. Gaurav Agarwal and Dr. Shalini Singh for taking the time out for this fireside chat and sharing their experience and their wisdom with us. Thank you so much for joining us.
It's a pleasure, and thank you very much for this invitation.
Thank you for joining us. I would now like to hand over to Kamal Narayan, CEO of the IHW Council, to take us through the valedictory session.
Thank you so much, Anisa, for this wonderful session. And thanks, Dr. Salini and Dr. Gaurav Agarwal, for wonderful deliberations and your inputs, your thoughts. And I'm sure they are going to help a lot in terms of, recalibrating our efforts towards cancer prevention and control. Thank you so much. So, good evening. When it comes to managing major healthcare crisis, speed is of the essence. We have learned and even practiced it all too well in tackling the COVID-19 pandemic, which trampled many fabled healthcare systems worldwide. Right from clamping a national lockdown and recalibrating our industries to produce COVID essentials, to inventing an indigenous vaccine, and most importantly, among all, deploying over 150 crore doses of it in just a matter of 365 days, the greatest driver of this all has been a sense of urgency and the topmost priority for doing whatever it takes for saving lives of the people. Similar, but may not be equal, responses were seen in this country for eradicating polio or ongoing mission against tuberculosis, or for that matter, groundbreaking success achieved in reducing maternal mortality rate among many other developmental indicators. Unfortunately, and even somewhat surprisingly, we have not been able to exhibit the same level of urgency or priority for many non-communicable diseases, with cancer being one of the most catastrophic among them. On the eve of World Cancer Day today, we are here with our third National Cancer Summit that endeavors to instill the same sense of urgency and national priority for prevention and cure of this disorder that killed over 8 lakh people in India last year alone. According to WHO, cancer is among the leading causes of death globally, and it is far too visible to all, as most of us personally know someone affected by cancer, whether we witness the fight of a loved one directly or see worry of their families and friends. Over the last few decades, or if we can say over the last few years, both oncology and cancer research have received a great degree of attention and fillip, both of which were much needed to tackle the rising burden of disease worldwide. However, not much has been achieved to reduce the impact of cancer by focusing on 6 critical engines of universal prevention: screening, early diagnosis, improving access, cure, and even palliative survivorship care. So is there a rapid way to achieve these objectives and plug the gaps in priority, policy, or practice that makes our people vulnerable to cancer and, more shockingly, to mortality in the absence of a coherent, affordable, and accessible response? We have been trying to answer this question with India's topmost policymakers, industry captains, caregivers, and even patients throughout the day. And I'm honored to have an illustrious panel of healthcare luminaries with me at this valedictory session of today's summit to deliberate on a rapid approach for tackling the pandemic of cancer that is engulfing the world aggressively but stealthily. So let me welcome our speakers for this evening. Dr. G.K. Rath. Dr. Rath is head of National Cancer Institute, chief radiologist and professor and head of Department of Radiation Oncology at the Dr. B.R.A. Institute, Rotary Cancer Hospital, All India Institute of Medical Sciences, New Delhi. Welcome, Dr. Rath, to this session. We have with us Dr. Professor Sudeep Gupta, Director, the Advanced Center for Treatment, Research and Education in Cancer at the Tata Memorial Hospital in Mumbai. Professor Gupta is a renowned medical oncologist and is a recipient of the prestigious Prime Minister Fellowship for Doctoral Studies. He is an internationally acclaimed breast and gynecological cancer expert and a prolific clinical researcher. Welcome, Dr. Gupta. We have with us Dr. Ashok K. Vaid, Chairman of Medanta Cancer Institute. Dr. Vaid is a noted oncologist known for his pioneering effort in bone marrow transplantation in India. He is a recipient of Padma Shri, one of the highest civilian honor in our country. Dr. Vaid is also an esteemed author of several research articles on oncology. So welcome, Dr. Vaid, to this session. We have with us Dr. Ravi Mehrotra, adjunct professor and epidemiology at Rollins School of Public Health, Emory University, Atlanta. Professor Ravi Mehrotra is a clinician, scientist, and who also sits on the Scientific Council of the International Agency for Research on Cancer of WHO in France. He led the ICMR, National Institute of Cancer Prevention and Research. We have with us Dr. R.K. Deshpande, Executive Chairman of Asian Cancer Institute. Dr. Deshpande is a renowned oncologist from Mumbai with nearly 3 decades of experience. Dr. Deshpande was previously associated with Kidwai Institute of Oncology, Tata Memorial Center, and is also the recipient of prestigious Padma Shri Award. We have with us, representing the patients, Ms. Rekha Gulbani, Director of Jagriti Indian Cancer Society. She is herself a breast cancer survivor and has positioned herself as a dedicated volunteer for cancer awareness, prevention, and support for all those who need it. And last but not the least, we have Dr. Sonali Dige, Senior Director of Medical Affairs at Pfizer India. Dr. Dige is responsible for medical contribution across all therapy areas and products of Pfizer. She is an ophthalmologist by training with close to 20 years of combined clinical practice and industry experience. So thank you all our speakers for this evening. And so let me begin this important session. We have been discussing the various aspects of, or various blocks of cancer care, prevention and control in our country. What we have been hearing, and if I quote just the previous session also, that there is a lot of efforts, everyone is doing their bit, but still we are not able to put out that coherent response which is needed. I just tried to, draw a parallel how we manage the pandemic of COVID-19, and not to, kind of downplay the impact of COVID-19 on people, on the world, which killed nearly 5 lakh people in our country. But cancer killed more than 8 lakh, and in just a matter of 1 year. So what was it, or what is it, that is not making everyone's effort work that well? Is there a disconnecting, are they working in silos? What need to be done, and how we can actually take a rapid approach towards it, because we have to be rapid against cancer before it, kind of goes really out of our control. So let me begin the session with Dr. Rath. Dr. Rath, where have been we lacking, and how we can tackle the pandemic of cancer as we tackle the pandemic of COVID-19? Sir, you are on mute.
Yeah, now it's okay. It's okay now.
Yeah,
Is it okay?
Yes, sir. It's
okay. Let me start with some positive notes and put some facts on the table now. I am the chairman of the Scientific Advisory Committee of National Cancer Registry Program. So instead of quoting other figures, let us quote our figures, which is ICMR NCRP figures. Now we have 14 lakh new cancer cases in a year, 14 lakhs. It's published now with Prashant Bathur. Out of which 7.8 lakhs die. Now let me start with some good things. In the last several years, you have, excellent panel here, all of us, everybody in the country. We have attended a lot of things. Let me tell you a few of them, just 1 or 2 of them. I think time is short. The cervical cancer incidence 45 years back when I joined AIMS in 74, it was 45 per 100,000. 45 per 100,000. Today it is 10 per 100,000. Achieved a lot, but as you told, lot is to be achieved. 45 to 10 in cervical cancer. 2 of the commonest cancer in our country are tobacco related and infection related. Both are preventable, not much of expenditure. Rapid is really complementing very good thing, but we might see the NCRP report now on the website. 7 of the 16 tobacco related cancers are showing negative trend. 7 of 16. It is our own figure published. 7 of 16 are showing a negative trend. Breast cancer is showing a higher trend. We don't have to discuss that. And let me come to a problem now. I was listening to last session also. If you refer, because it's being listened by many people, student must be there. 3rd of September 2019, Lancet Oncology. 3rd of September 2019, Lancet Oncology. Cancer is the #1 killer in higher income countries and many of the middle income countries. This is a McMaster study, 5 continent, 25 country study. So cancer is already #1, killer. We have to do much. We are doing quite a bit, but because of our problems, we are adding one Australia every year also. And we need to do, and Rapid is really complementing a very good thing. A lot of things have already been done. We are doing a lot of things. I'm sure I'll come in between. I am outside the country right now, but I'll be joining from time to time. Thank you.
Quick follow-up questions. You mentioned
please.
You mentioned about. I'm also a very optimistic person, so I'm not trying to draw a negative.
I'm glad.
I'm just trying to understand.
Cancer. Okay. Let me tell you. Cancer is the only disease which is curable. Diabetes, hypertension are not.
So
diabetes, hypertension, thyroid, not are curable. Cancer is a fantastic disease.
Great. And that is where the key of this whole discussion lies, that it is preventable, it is curable, still why people are dying. So sir, a little small question. You mentioned
6% preventable, 60% curable.
Yeah. So many of them are preventable. We have, and you mentioned about a cancer, which is cervical cancer. You talked about interesting, decrease or remarkable decrease in the number of cervical cancer cases in India, still, I believe, and you can correct me if I'm wrong, because I can just quote figures which are publicly available. You will be having more, kind of insight, information.
No, you can quote our figure. You can quote the
Almost
national figures, ICMR.
60,000 women are dying because of cervical cancer every year. Is that true?
I agree. I agree. Totally agree.
So,
totally agree.
and when did we get, sir, when did we get the cervical cancer vaccine? We have a vaccine for, papilloma virus.
Human papilloma virus, HPV 16 and 18.
Yeah.
We have the vaccine.
We have a
yes.
vaccine. So how long it has been the vaccine is available for people?
Well, I think it's in at least more than 10 years. More than 10 years now.
And have we been able to adopt that vaccine for the people of our country, or the women of our country, or the girls of our country, as we have adopted the vaccine for COVID-19?
Yes, at individual levels. You, me, and the esteemed panel members, we all have done it. We have all have done it. It's not in the national program as you find National Malaria Control or Tuberculosis Control Program. It is not yet in the national program.
So that answers my question, sir, that it is still not a national priority to save lives maybe from cancers. So let me go to Dr. Sudeep Gupta. Dr. Sudeep Gupta, what is your take? Not to again, depict a wrong picture, but there are two, so there are some of the glaring facts in front of us, which says that, okay, we are all able to do something good. We have the capacity, innate capability of doing something great, and we have done it in many areas. Why we are not able to do in cancer? And especially, I just want to bring one point. In the last session, and this is again, you can, kind of correct me because I'm not a doctor. We have been talking about cancer being a lifestyle disease. And the moment you say that it's a lifestyle disease, the onus of the prevention or cure goes on the people, because it is your lifestyle which is killing you. Shouldn't we call cancer sometime a life cycle disease also? Sir, Dr. Gupta.
Checking out.
So thank you very much, first of all, for inviting me to your nice panel discussion. I think you are doing an excellent job of bringing up awareness among all stakeholders, including ourselves as well. First of all, I would like to agree with what Dr. G.K. Rath said, that there have been many positives in the cancer scenario in India in the past many decades, and it is all not negative news. There are many pluses as well. The second answer to your question is that cancer, is not like an infection. There are no easy solutions. You can say that I will prevent COVID by giving a vaccine. You can say that I will prevent diphtheria by giving a vaccine. I will treat this infection with a 5-day course of antibiotics. Unfortunately, cancer is not like that. Some of the best minds in the world have grappled with the question of cancer for the last hundreds of years, and we are where we are today. Even in the most advanced countries with the most resources available, it is not the case that all cancers are preventable and all cancers are curable. It's not like that. In fact, I would like to tell you that on a per 100,000 population basis, our total incidence of cancer in India is actually about 1/3 to 1/4 of the advanced countries. And it is right to say that 60,000 people are dying and 100,000 people are dying and whatever else is happening, but you have to look at the denominator. The 60,000, I mean, I'm not saying that 60,000 people should die, everybody should be saved, but nevertheless, the denominator is also 138 crores of population. Now, having said that, the route, in my opinion, what can be done and what should be done is to prioritize public health infrastructure in India. And I will come back to this theme again and again. You see, we have islands of excellence. We have All India Institute of Medical Sciences. We have the IRCH and the National Cancer Institute led by Dr. Rath, which is an island of excellence. We have some other, public sector, 2 or 3 other or 6 other hospitals. But for the country of the size of India, 4 or 5 or 6 or 7 will not do. And there are excellent hospitals in the private sector, and they do a wonderful job of providing access to care for that section of the society which can afford that infrastructure. But unfortunately, even today, 95% or more of our population cannot afford the private healthcare infrastructure, especially for a complicated disease like cancer that requires large investments, including capital investments. So you see, what I would like to tell you is, you talked about cervix cancer. Now, cervix cancer, in most instances, when it does happen, it requires treatment with a technique called radiotherapy. Now, radiotherapy, it's not straightforward and simple. It requires external radiotherapy. It requires internal radiotherapy with a technique called brachytherapy. Now, in the public sector healthcare domain, we need to equip our public healthcare infrastructure with modern radiotherapy machines with enough trained manpower to deliver both external and internal radiation, as well as the drugs and the other multidisciplinary paraphernalia to care for those patients. And I'll tell you the other problem. In cancer, Sudeep Gupta sitting in one room cannot treat the patient. You need a pathologist, you need a radiologist, you need a surgeon, you need a medical oncologist, you need a rehabilitation. So the manpower requirement is more in numbers as well as in terms of expertise. And lastly, let me say that the government of India, in my opinion, its heart is in the right place. I think it has done a reasonably good job. There are a lot of new hospitals that are opening up. There are a lot of training opportunities. We have the National Cancer Institute. It did not exist until a few years ago. There are many other AIMS hospitals which have oncology departments. And I think that the situation is improving and it will continue to improve. But I have to say that in a disease like cancer, there is no quick fix solution. Unfortunately, COVID has caught everybody's attention all over the world. But in my opinion, conceptually, philosophically, and scientifically, COVID is a far easier problem to tackle compared to cancer. Cancer is a much more difficult problem to tackle. Sorry, maybe I gave you a very long answer, but
no problem, sir. Thank you so much. You actually tried to put things quite in, I think, perspective. But I agree with you that cancer care, cancer prevention, cancer control is all a complex problem. I believe COVID was also very complex when it began. It became simpler over the period. But at the same time, it is a complex problem. But there can be a lot of simple actions also. And some of the actions, I think we all have been discussing time and again. Kind of adopting, if I can use the word, rapid adoption of, let's say, a vaccine which is available for last 10 years in the national immunization program. I don't think that it's a really a big complex decision to be taken, or a big complex decision or a step to be put forward. Let me go to, before I take some of our women panelists.
I have to tell you a quick rejoinder. Dr. Rath was absolutely spot on when he said that the incidence of cervix cancer was 45 years ago. It is 10 today. And if you had introduced the vaccine then all this reduction would have been attributed to the vaccine. Now, let me tell you that vaccine is given to girls who are 12 or 13 years of age. It will prevent cancer when they are 50 years of age or 45, because that's when cervix cancer happens. So, even if India was to start the vaccination today, it will impact the cancer incidence in 2050 or in 2055, not today. So, it's not that, some great calamity has fallen to the women of today if vaccine has not happened in the past 10 years.
Great. I think that's even put the things in a more better clarity. But again, we need to save the the women in future also. So we'll come to that. Dr. Ashok Vaid, what is your thought about have we been able to kind of activate all that needed for cancer prevention, diagnosis, treatment, palliative care? Because there seems to be a lot of broken ends in this entire framework.
Kamalji, thank you so much for once again having me on the panel, and congratulations for raising the issue about the awareness. And I was listening towards the end of the last session that the comments made that the awareness is the key. Now, I agree with you, and I agree with my colleagues from the professional side as well. And let's go back to the 40-60. So we know that 40% are preventable. Let's put a list on a piece of paper. What is preventable? Tobacco-related cancers are preventable. Cervical cancer is preventable. Everybody knows about it. Now, let's go to tobacco. India is a signatory to the International Framework Convention on Control of Tobacco. And India was one of the first 40 countries who signed that document. All that it says is set your deadline. A lot of countries have set the deadline at 2030 to go tobacco free. India is a vast country. A lot of people depend on tobacco cultivation. All that we need to say is it 2050, 2040? And meantime, give the farmers an opportunity to move to other crops. So you need a downstream and an upstream, both the actions. So tobacco, if tobacco is linked to 40% of the cancers, imagine over the next 20, 30, 40 years, these 40% cancers, a lot of them would be controlled. Cervical cancer, Dr. Sudeep has made a very brilliant point that we haven't missed much, but we can catch up. And then there are a lot of people. In fact, I'm involved with an NGO. We created this NGO only for cervical cancer vaccine awareness and making the vaccine accessible to people. It's an expensive affair. It's not like the routine vaccinations. That's another problem. You and me got a vaccine, the COVID vaccine, for 250 rupees. The cervical cancer vaccine is not the same story. Now, the next 60%, what can be treated and what can be cured, there is an issue about infrastructure. There is issue about the expense. There is an issue about access, geographic distribution of the facilities. Delhi, let me put things in perspective. The Delhi NCR has 30 cancer centers clustered in a small area of the country, which is the highest concentration of cancer centers. And look at the geography around. There is an incongruity. The facilities available today are only for treating about 30-40% of the cancer patients. Others don't get quality treatment. So what's the solution to those 60%? The solution is that India needs its own medicine. We need to invest into research, infrastructure. We haven't produced anything. Not a single drug has come out of India. No anti-cancer drug has been brought out, which a blockbuster from India, or a radiation machine, or a diagnostic machine, or a mass-scale applicable diagnostic test has originated from India. So we need a massive, Dr. Rath is spearheading the National Cancer Institute. That's a step in the right direction, but we need to move quickly. We need many more centers like that. So India needs its own medicine. We need—
Wonderful. Thank you so much, Dr. Vaid. A few key points or key words which are coming, from the three experts who spoken up so far is that we as a country have done a lot of remarkable progress when it comes to even for relatively maybe newer problem, which is cancer, because as we are getting or enjoying a longer lifespan, as we are getting a more modern amenities around that, or we are progressing from being a developing country to maybe reaching towards what everyone aspire to be. This problem is going to, I think, manifold over the time. So it is just a beginning maybe. And we have seen in the last, I think, 2 decades, we have seen remarkable growth in the number of cancer cases. And the number of death cases as well, because as Dr. Sudeep and Dr. Rath also have pointed out that the Western countries, or maybe let's say developed countries, are seeing much higher number of cancer cases, but the death ratio is much lower than what we see in our country. And that shows that there is something which is not right in the process. At the same time, and some of them which being highlighted by Dr. Rath, Dr. Gupta, as well as Dr. Vaid. Now let me go to and let's hear from the patient point of view. Somebody who has gone through the disease, have won over the disease, and have seen maybe firsthand the cracks in the system. Ms. Rekha Gulbani, what has been your experience when it comes to, and what do you see, and what, since you are now working with patients, you are trying to support them, what are the biggest challenges you feel? Because one thing, as all our experts have said, 60% of cancer cases are not preventable. They are going to happen. And in that case, the diagnosis, the cure, and even palliative becomes extremely critical. What is the state of the affair from the patient perspective?
Yeah. Actually, first of all, I want to thank IHWC for making me a part of this August panel, and always making me part of all your sessions, and which opens our mind, gives me so food for thought, and that makes us improve as patient advocate. When I got cancer 24 years back, I also was like other people, went to hospital very late when the things were going to be out of control, on the verge of that. I was on the verge of stage 3, 2B, and chances of survival seemed to be quite bleak. But with the efficient hands of IRCH under Dr. Rath's team, I survived, though I suffered a lot. But at that point in time, as you have said, all these problems, I never knew about this before I got struck by cancer. I saw other women having financial issues, coming from far off places, having no awareness, no accessibility, not affordable medicines. All these things, I forgot about my own problems, and I started thinking of their problems. And then I promised myself, and my husband told me, you try to be all right, and then try to help these women. And that's why I came into this field, that by grace of God, I hardly had any other problem other than the disease. But these women do have. And when I came into this field, then I realized the need of resources. We patient advocates should not only try to give them emotional support, but we should try to make an information bank like resource directory and collect information from where they can get. There are facilities, infrastructure, services, resources available in the society with the government, and the patients are not aware of that. So awareness is the basic things. If they are aware of those things, they can reach out there. And then right from the basic things, again, the threads are given to me by IHWC, rapid. We must understand, we must realize, R stands for, realizing, that we need awareness at every level. Those people who don't know anything about cancer, we have to make them realize that it is important for them to understand cancer, its symptoms, its prevention, and everything. If we know it, then we should know how to get the right kind of treatment. Awareness. If we know how to get right kind of treatment, another level is we must have awareness about how to cope with the side effects of it, and maybe later on, a few months later, a few years later, after. So at every layer of your life, you need awareness. We should realize. And for that, Indian Cancer Society has been going to place for awareness. Especially we had adopted Mathura, Vrindavan, and an area called Najafgarh in Delhi. So we try to go to door, and we try to train the ASHA workers, other social workers, because we will be there for 1 day or 2 days. And somebody should be there permanently. We make them our ambassador. See to it that not only the people open their mind to cancer, not to run away by listening to the word, but they should also act upon it. Your second point is act now.
Rekha ji, thank you so much. We will reach, go to each point of that later, but let me just, you have made a very important point that, the access to information, awareness, and most importantly, realization that whether I can get cancer or not. We saw a universal realization among everyone that they can get COVID. And that is why we saw, I think, one of the biggest behavior change in the history of humankind, especially because the number of humans right now are much higher than in the last pandemic. So we can, I think, safely say that it was the largest behavior change which happened.
Yes, you have put it in a very apt manner. The whole community, like they know about COVID, everyone should know about cancer and realize that they do need it and prevent it as far as possible.
Yeah. So just to take that point, let me go to Dr. Deshpande. And Dr. Deshpande, just a small point. There is a lot of darkness at your screen. Is it intentional or it is?
No, it's not that. I'm very sorry. I'll just change the angle.
No, it is like, I'm talking to somebody who does not want to disclose his identity. So,
No. There's nothing secret about it. So is this better?
Yeah, absolutely. I can see your face now, sir.
Okay.
Yeah. So, Dr. Deshpande, one of the point which was highlighted that, and this is one important, I think, part of this whole mechanism which is needed for effectively preventing and controlling and curing cancer. Awareness. Do you, as a doctor, and I'm sure you would also be involved in a lot of those awareness practice, all the hospitals are doing, what kind of resistance we see? Because when I send a message, to, let's say, for example, today, and I do it very frequently, I send a message that anyone can get cancer and it is important to know about it. People reply to me that why you keep scaring people all the time? Now, but we are getting into 40s and will be getting in 60s, 70s. Our lifestyle and maybe the air around us can trigger something, and we need to know it. Why do people have such a kind of what is stopping them from the basic realization that cancer is a disease which can come to anyone and everyone? We need to be prepared. We need to be aware, alert, and take timely action if it comes. Dr. Deshpande.
Yeah. First and foremost is thank you very much to the IHW Council. Number two is, this analogy with COVID is something very important because, see, COVID is the thing which initiated this whole discussion about cancer, right? So what happened is when the COVID thing began just about 2 years back, what was the fear? The mortality could be anything from 13 to 17%. 1 in 5 people could die, and that's why everything was shut down. The whole war effort started, everything. Today, everything is opening up because now with Omicron coming in, the mortality is less than 0.7%. So, okay, we can continue doing whatever we want. We can get COVID, but we are not likely to die. So don't worry about it. What happens in cancer is basically cancer is people talk in terms of lay people language, like cancer means cancer. There's a high death rate involved with that kind of thing. So that is why people don't want to know that there is a danger in a particular area. So don't tell me about cancer that I'm likely to get. Nobody wants to know when they're going to die. It's very, very surprising. We take pride in our so-called Vedic culture, perpetual soul and all that. But nobody wants to die. This is, including me and you. I'm sure about that. So this is a problem, So there is a definite resistance to knowledge also everywhere. Now, number two is now, my earlier colleagues brought out certain points. See, cancer incidence is not going down. It is definitely going to go up. We have about 14 lakh new cancer cases now. In about next 10, 12 years, it's going to cross 25 lakhs. All that has happened is redistribution. Cervical cancer has gone down, breast cancer has come up, so on and so forth. But if you take an overall cancer mortality, almost about half of cancer patients will die. 6 or 7 lakhs of patients amongst those, not exactly from that same population of 14 lakhs will die, but half of them will die. So which is like 50% mortality. So who wants to know about 50% mortality disease? I don't want to get that disease. That's why there is a definite resistance. Now, how do you really tackle this particular thing? That understanding of cancer, the education of cancer in a very, very diluted kind of a manner should actually start from the schools itself. So, yes, there is a disease called cancer. See, we teach children about so many other diseases. We should also teach them about cancer, which is a very, very important thing, which demands a whole lot of resources on the treatment. Probably this is a disease which demands the maximum amount of resources because it's a linear kind of a problem. In case of a coronary problem, you do a bypass, patient is all right for 10, 20 years. Same thing is not the thing with cancer. It's going to demand money from you all the time. Societal costs of absence, the emotional costs, financial costs, everything is very, very high. So best is to actually train people. And if you don't want to have that problem, there are ways of doing it. Obesity can be minimized. Diabetes can be minimized. Tobacco can be practically be eliminated over a period of time, as what my esteemed colleagues have already mentioned. So all this kind of thing has to change over a period of time as a culture. It cannot happen. This can't be an acute phase kind of a thing at all. So it has to work as a culture, and only then the thing can actually improve.
A wonderful suggestion, Dr. Deshpande, and I think this has been time and again reiterated by many people that how we can make school itself or at a childhood itself we can able to convey people and kind of make them more open to for these discussions or for these information, so that the resistance which we see at our age now, it's not there, and that is linked to many other I think behavioral aspects also. So the tobacco eradication is not, I think, can alone be done by the government or by the policies, because otherwise if it would have been a possibility, the dry states would have been completely alcohol free. And we all know that how much of that happens despite that those kind of restrictions. Let me go to Dr. Ravi Mehrotra. Dr. Mehrotra, you have been seeing a lot of policy aspects, research collaboration aspects at the global level, and also you have been part of this and very strong advocate of tobacco elimination, also eradication, as Dr. Vaid is. What are the challenges which you see at a overall ecosystem level, that at one side we are seeing the increasing number of cases of cancer because of tobacco, which is preventable. At the same time, we are also seeing that the consumption of tobacco may be increasing. We are not, despite being signatory to the framework, we are not able to implement it completely. What are these, why we have such a pitted situation, how we can bridge all that, and can there be a framework to facilitate, these actions at different level, which are targeted at bringing one major outcome? Dr. Mehrotra.
Thank you, Kamal, for having me on this show. As always, it's a pleasure. And it's a great honor to be among my colleagues from practically every major center in the country. Firstly, let me tell you the major, aside from tobacco, of course, which causes practically 40% of all our preventable deaths and 20% are infection. The major cause of death is actually not under our control, which is aging. As lifespan, in 1947, Dr. Rath talked about independence, our average lifespan was 47 years. Now we are close to late 60s, sometimes in 70, depending on where you are based. So aging is something we cannot really control, and we would love to get older. And Dr. Deshpande said, we don't want to die. Nobody wants to die, but we want to live a healthy life. So
we don't want to get old.
As the country, there is a transition to a higher economy, cancer has to increase. I mean, our population is now it has leveled off by and large. But as the aging increases, cancer has to increase. So I don't think we should be taking it as the India is happening. This all over the world, it is the same issue. In the developed world, it is the same issue. Coming to your question about preventable causes, as far as I know, we are among the first countries to sign the FCTC or the for the WHO treaty. But we have, if one takes the positive news, the consumption of at least smoking tobacco is actually going down in our country. As Dr. Rath had mentioned initially, the tobacco calls 6 out of the 12 or 14 have actually come down. We have already met our 2030 figures, but before we start celebrating and go balle balle, the issue is look at the population of the country. So the population, until it comes down, the actual numbers will go up. Percentage-wise, we are actually doing relatively well as far as smoking is concerned. Our problem is basically smokeless tobacco. 70% of all tobacco consumed in this country is smokeless. Your gutka, pan masala. And it is not only tobacco, but also supadi or areca nut. Most people in this country do not know that areca nut is an independent carcinogen as defined by IR. Now, when you say why we are now not able to implement, see, the government is only one part of the whole show. It is the human being which is important. Tobacco industry is the only industry, to the best of my knowledge, in the whole world which kills or maims 50% of its consumers. So they have to get new consumers adding on, and that is how, just like cricket, we talk about catch them young. Tobacco is basically catching them young. And I don't think you have to go very far. The holding outside your own house will be showing pan masala being advertised by your actor friends or actresses. And they have a same name, what is known as surrogate advertising. So basically, it will be talking about it will be talking about elaichi, or talking about saffron and whatnot. So that is where I think the media has a role to play to not only expose these people who are making not only millions but billions of rupees at the cost of the youth of our country, who are the new consumers of tobacco. So to answer your question, yes, deaths are going up. Probably what we talked about of 14 lakh cases, the actual number will be much more, because there are so many people who die of the disease without ever being reported. There's some excellent efforts by my previous organization, ICMR, is getting the National Cancer Registry. Unfortunately, till very recently, our largest population state, that is Uttar Pradesh, and even Bihar, Uttar Pradesh has got a cancer registry now. Bihar still doesn't have one. So there is a certain amount of underreporting, but by and large, if you take our National Cancer Registry program, we're doing a great job, much better than many other neighboring countries and countries of the same size. However, when you talked about what can be done, I don't think we can, it is, if I may take the analogy of a dog chasing his own tail. When people come to us in the late stages, we are not able to do well. Nowhere in the world you will be able to cure all cancers. It's not possible. So the option really is for a country like India and similar place country is prevention. You already talked about that. And the other thing which I think Rekha ji also mentioned was early diagnosis. And that is where the importance of improved diagnostic skills, improved availability, as well as at the end of the day, the people on the road have, as you have talked about COVID, have to be knowing more about the importance of prevention and early diagnosis. I don't think all our esteemed colleagues sitting with the expensive monoclonal antibodies and latest biosimilar, India will never be able to afford it, at least in our lifetime. So, of course, where they can afford it, where there is treatment available, they should be given. I'm not saying they cannot. And 80% of our medical care is under private hands. So you have to be making sure that the private enterprise, and we have people from the various drug companies also on this panel. I would love to see how we can make affordable cancer care possible. That I think is something we haven't talked about, and I'm sure you will be going about it as we go further. Thank you so much.
Oh, thank you so much.
If I could make a small point, I think if they make it mandatory for all the doctors, even if that patient comes for some other problem, if she goes to gynecologist, she should make it mandatory to have mammography and this pap smear. If they go to the doctor, they can make it mandatory for prostate test. They go to dentist, they should look for the oral cancer. You know, even if the patient has come for other disease, the doctors themselves should do it and tell them, now this is there, it may be cancerous, you should avoid this. If different doctors also make it a point that with all other diseases, they club the cancer thing, so that when the patient comes without knowing, the patient comes to know that I have to go through this, you know. So if they make it mandatory for the doctors.
Thank you, Rekha ji, for bringing this point. However, this may also have, it can be debated further. Let me go to Dr. Sonali Dighe. Dr. Dighe, Dr. Mehrotra talked about making cancer care affordable. And when it comes to the affordability of cancer care, the one important thing, and I think the government has to, or let's say public health system, not talk about government because it's our money. It is the public money which need to be utilized for better healthcare system, which is affordable, accessible for the people. But at the same time, it is also the one important component of the care is drugs and medicines and the technology and the innovation, the research and all that. You are representing, one of the biggest, organization in that space. How do you see that? If we compare it with the a more developed world, we see that there is a lot of kind of progression in terms of the medicines. There we have very effective drugs available now. Is it reaching to the Indians who need it, or if it is not, the pricing alone is a problem, or the out-of-pocket expense is a problem, or the lack of government net safety net is a problem. But at the same time, if a great medicine is available on the face of this earth, I believe it should be available for all. So what is stopping it?
So thank you again, ISWC, and for inviting me here. And it's really an August gathering. I see that except for me, all other medical doctors are oncologists here. So I'm learning from everyone. So when you look at the, and of course, it's a difficult question to answer, right? When you talk about the affordability and access, first of all, I think it starts from getting the medicine to India. And I can, one of the things I could tell you is the focus for companies like us is actually equitable or equal distribution of healthcare. And that also includes giving access to our medicines to Indian patients, not just access, but as early as possible. So efforts are being made right from the clinical research step, because there are certain regulations that require Indian patient data to be included in our clinical trials, and we have very specific efforts and advocacy that we have been doing to see to it that we get more and more clinical trials in India in this in oncology. I wouldn't say we have reached there. We are better than maybe a few years back. There is a lot still need to be done, but we are making constant efforts to see to that we do get the clinical trials to India. The second part of it is the accessibility, and again we put together comprehensive programs that would help patients and do have a patient access programs to see to it that our medicines would reach as many patients as possible. Now let me go back from here to where do the efforts start? Actually, the efforts, here we are looking at all the hospitals as well as doctors as our partners to even improve the diagnosis. So our efforts start at partnering to improve diagnosis through awareness building, enhancing the knowledge of our doctors who may be in outreach areas. One of that initiative we are doing with NCA as well, we are looking at enhancing the knowledge of medical officers in few districts from Haryana. We also are making efforts to train doctors through different preceptorships, again, to improve not just the diagnosis, but also the management and, making sure that doctors are aware of the protocols, where possible, getting our global connects to have hospitals like MSKCC to come to talk to us oncologists from there to talk to our oncologists. And I would say then the next step also comes about the new medications and our new molecules that we are trying our best to get to India as early as possible, if possible, at the same time at the global launch. And that's my personal goal for me, to get the new medications, not just in oncology, in all the therapy areas, to be launched in India at the same time as our global launch.
Thank
and
you.
I would say these are the 4 pillars, 3-4 pillars in which we are currently working to improve access of medicines to India.
Thank you so much, Dr. Sonali, for highlighting this. And yes, I think that's an important aspect of, I think, again, the rapid access and adoption of these, the new innovation has to also happen. I think that we have almost spent 45 minutes and more than that in this session. And broadly, we discussed about that. What are the resistance? What is the need of the awareness? Why can't, how we can have a cancer control in line with how we have seen efforts from both public as well as the providers or the government or the provisions, the people who provision health in COVID-19. Now, I think broadly what comes out in this, and which Rekhaji was also trying to highlight, is that it's very clear that and most of our experts have reiterated it, that it is very important that there is a realization among the people that as they are living longer, as their lifestyle is changing, as there are multiple other factors, which are lifestyle factors, which are environmental factors, which are out of their control. And many times there are even professional, occupational hazards also involved. Cancer can happen to anyone if, at some point of time, especially when you are living longer. This realization has to convert into something where they have to act. They have to act by modifying their lifestyle. They have to act by seeking things which are helping in the prevention, be it breast examination or vaccination wherever it is available, let's say especially for cervical cancer, or it is for that matter going for the general healthcare screening, and then practicing healthy habits, eating healthy, sleeping well, and all those things are equally important for the people. De-stressing, maybe stress is something. So if infectious disease does not kill somebody, stress can. So I think that is also something very, very important. And then informing is spreading awareness further. Informing others is one aspect of the rapid approach which is needed from the people. So if you see that realize, act now, practice, RAP, inform, and then comes the D, defeat cancer. I think this rapid approach has to get instilled in the psyche of the people. And for that, there can be many approaches from, bringing or introducing cancer awareness, education from the school so that they are more open to hear it, to all other aspects, not only cancer awareness, living healthy is an also important point to be reiterated again and again. From the provider side, so I would like to have one more round of inputs from all of you, that what are the problems, challenges at the provider side. So we are not discussing awareness is something, realization is something, has to happen. Does our health providers, and especially not provider, if we can say that those who are responsible to provision our health, are having enough realization or recognition that cancer is something which they have to act now against it. So let me go to Dr. Sudeep. Dr. Sudeep, you had mentioned that the government of India doing fairly decent work in this space. There are a lot of frameworks, programs, NCD programs, and all that. Even in the last session, Dr. Salini was saying that there is a whole mechanism available from CHC, PSC to the neighborhood hospital to district level hospital screening and all that. But at the same time, we all know, I believe, is that it is very difficult for somebody who has in a small town of our country, having a stomachache. It's very difficult that stomachache can be diagnosed as ovarian cancer very early, because it may be for months, the patient may be on painkillers, on something like else, maybe 10 other tests might be done, but our system does not have that kind of arrangement, I believe, think so. Maybe since you people are more on ground, you may have a different view on it. So does or do our healthcare policy makers or decision makers have this recognition, and they are really, like they did in COVID, are they really thinking about tackling cancer in that manner?
So thank you for asking me that question. You are asking me whether the policy makers are cognizant of the magnitude of the problem and the urgency of tackling it. That is, I think, your question.
Yes.
I believe that most of the relevant policy makers in India are cognizant of the problem, and as I think Dr. Deshpande pointed out and others also pointed out, cancer is gradually increasing in incidence, and it will definitely increase in burden in the coming years because our population will still grow for the next 30 or 40 years before it stabilizes. So I think the policy makers are aware that cancer and other non-communicable diseases are going to constitute a big healthcare burden in the coming years and decades. But the question is whether, what prominent priority there simply because of the fact that it is a serious disease and it is going to increase in the years to come. So I do think that the single most important thing that policymakers can do is to increase our spending on healthcare. And I think COVID has, I should not call COVID a blessing by no stretch of imagination, but COVID has definitely made everybody cognizant of the fact that healthcare is an important thing. And I think it has at least come on the radar screen of everyone, including the policymakers.
That's wonderful, I think, and quite reassuring, Dr. Gupta, that the policymakers are cognizant of the problem.
Yes, but I'm not reassured that the healthcare spending will be increased or not. So that we have to wait and see.
I think by increasing the healthcare spendings, it's not that cancer alone. Actually, it is like one stone to kill many birds, not just the 2 or 3 birds, because there are many other disease burden can be controlled by doing just that. But that is the biggest challenge, which is not happening for quite some time now. Dr. Deshpande, what is your opinion? Dr. Gupta is saying that policymakers are cognizant, but at the same time, he's also highlighting that it is not that the money is not being spent on cancer care. It is happened. Yeah.
You start right from the beginning. Okay. Now, what is the recommended bed to population ratio? It's 2 to 1,000, right? This is a WHO recommendation. How many beds do we really have? We have 5 for 10,000, right? That's the proportion we have. And 69% of these are all in urban areas. So there is a gross mismatch to start with. Can we correct this? I don't think that any government can ever correct this, because ultimately it's going to be a catching game altogether. Even today, a developed country like US doesn't have really adequate kind of facilities. All those European countries are very, very small, 1 crore population, 1.5 crore population. They'll just fit into a megapolis like Delhi or Mumbai or something like that, with their huge incomes, they can actually provide for it. So I think being capable of providing for everybody everything is a dream which will never going to come true. This is number one. Number two is, I think what we need to concentrate on is prevention rather than treating the things. How much did the government really allot per patient in case of COVID? And how much is it likely to need per patient of cancer? If you really work out the statistics, you're going to go mad. So it's going to be like 1 into 100 times or something of that sort. Here, the poster boy is very evident and attractive because everything is played out just in 2 years. And that is why this whole thing is happening. But it's not going to happen in case of a cancer. Cancer incidence is going to go up. So what we need to do now, see, my esteemed colleague said that incidence of cancer cervix has fallen from 46 to practically 2 to 10. In case of developed countries, it's almost about 2 per 100,000. Now, all this in India has happened without any kind of a vaccination. So those naysayers about the vaccination, they will say, why do you want to go into the vaccination mode? Because each vaccine is going to cost you 4,000. Why do you want to deploy your resources in that direction? It's only the cleanliness, the awareness of the first child, the breastfeeding, and all that kind of a thing which has really helped. So all this can certainly help. So education is something which needs to be prioritized. And I think hats off to Mrs. Gulabani, who set out the ball rolling by a fantastic agenda, that there has to be a resource kind of a accessibility, which is very, very easy today with internet being accessible to almost everybody. And then the closest kind of a resource, which is their institute. Now, we have the National Cancer Grid, which is an association of 262 cancer institutions, which was started by the Tata Trust. And so you can identify your closest center. It's exactly like the airline announcement that the closest door may be just behind you. So it is like, so you have facilities, you have awareness, you have training, all these things. If you really start making an impact, you can actually reduce the incidence of cancer, number one. You can improve the survival, number two. You can conserve a lot of resources. Now, we keep on talking and harping that, government gives only 1.6% of the GDP as a health budget. But don't forget that there is 5% equivalent which is going into private. So you're looking at almost about 6 to 7%. Now, US has 15% of the budget going into health. Forget about it. You'll never be able to do it for the next 50 years. So not in our lifetime. It's not going to happen. Don't even think about this particular thing. So concentrate on what is possible. You need a real brainstorming on how to set up an agenda. So concentrate on whatever is possible, improve your education level, have good core centers, and have the hub and spoke model. This is a thing which is achievable, doable, and I think this is the way we need to go.
Thank you so much, Dr. Deshpande. Very important point, and I think it is a lot of lessons are here in to learn by that. Stop running after thinking of that we will be having a health allocation like the Western countries. So let's look for something, not run after the mirage. Look after something which is more feasible. Dr. Ashok Vaid, if that is the situation. So let's agree that there is nothing going to be remarkably changed in terms of the per bed per person bed availability, or for that matter the increase in the healthcare expenditure. And Dr. Deshpande is also highlighting a very important point that almost 7% of our GDP is being spent on healthcare, including both out of pocket, private, and the government. Now, is there a way to kind of pool, connect, collaborate, kind of join the existing resources? Like, for example, he mentions about the National Cancer Grid. 250 plus hospitals are there. Similarly, is the people are aware about it, and I think there is a lack of awareness. But at the same time, not only this. Many other aspects which can be done, or do you think that there are still a lot of efforts which need to be put in by the government? Like, for example, if they are cognizant, shouldn't there be cancer notified disease at all the states of our country? Maybe that will help in allocating our existing meager resources in a better manner. Does every state of our country has a quality public health institution for cancer care, or a super specialized, from the government? Are these, maybe they are big intervention which need to be brought in, but do you think that there are certain lacking from the people who are provisioning health? They have to do it, and at the same time we also need to see that how we are going to collaborate and bring together the existing resources, so that it is not that always we are cribbing that what is not there, but we are also able to use what is with us in a better manner.
So Kamalji, let's first understand where do the resources come from. Government has a limited pool, limited budget for that, and the private sector obviously is doing its own bit. But one of the key points is that we want the numbers to go down, and those who are yet afflicted with cancer, we want to increase the survivability, their longevity more and more. I think that's the point. Now, you have a huge budget on the CSR today. I think it's about 30,000 crores or 40,000 crores an annual budget. You have a cess on petrol. You have a cess on everything possible. Let's go back to the 90s. What happened with HIV/AIDS? We got to know that this disease is going to overrun the population. And therefore, there was a huge campaign, the frenzy. I call it as a frenzy, and this is a very pet subject I would like to talk on. How did we control the HIV/AIDS? So let's not compare directly HIV and cancer, but the only comparable factor is that we brought up the awareness factor. We even trained the barbers that please do not use. So that's the way the government worked. The government can do it. That's the point I am making. All that we need to do is create a frenzy about it. On the electronic media, print media, everywhere, there were matches, cricket matches between HIV positive people and the parliamentarians and so on and so forth. The Bollywood stepped in, everybody, it was all over the place. The second is,
you are highlighting that there has to be a campaigning mode.
Absolutely. The other is, treatment of cancer is unfortunately still very elitist. What happened? I made a point earlier also that India needs its own medicine. $1 per patient treatment cost of HIV drugs actually changed the story in the entire African continent and elsewhere in the world. And India did it. Nobody else did it. So we need our own medicine. So invest in infrastructure, invest in research, our own medicines, bring the frenzy, bring the awareness level. Now, about making it a notifiable disease, I think you can't do it till you don't have the infrastructure. Tomorrow, everybody walks into the hospital to get the state-of-the-art treatment. That's not possible. That's a dream too far. And we know that our infrastructure is not at par where it should be. The number of cancer centers, sheer number is less. The cancer centers are not equipped to the standard. Once you make it a notifiable disease, then you are taking a lot of onus on yourself. The government has to take the onus on itself. So it's I think the awareness, the frenzy, the pace of dissemination of that knowledge has to be actually brought up. That's my take on that.
Thank you so much, Dr. Vaid. Rekha ji, we need to go into a campaign mode. We need to take up, cancer control the way HIV elimination, or maybe control, or polio eradication. And I try to draw parallel. They may not be same in the nature, but at the same time, they shows priority. That okay, this is a problem, we want to address it, and that shows the bigger, higher cognizance from the people who are supposed to do that. Private sector is doing a lot of work in terms of cancer awareness, and we can see the charity institutions. So Tata Memorial doing wonderful work, in our country. But as a patient support volunteer, as a health advocate, as a patient advocacy, volunteer, how do you see that? So if we leave about what all government can additionally do, what are your suggestions? And a little quick one, how the existing ones can be clubbed together in a manner so that there is a higher kind of support for those who get this disease, and there is a faster, rapid approach for them to access treatment or whatever cure is needed.
Yeah, I 100% agree with Dr. Ashok, where he has given a fantastic point with which I have been trying for last so many years, that we should have a campaign. Until there is campaign, it cannot be solved to great extent. We can solve it here and there, as you said, where we are in our own localities. Secondly, we should first try to eliminate it at the grassroots level. We always talk on the policy making, on the great thing, the powerful people. You may make anti-dowry laws, and unless it reaches into the souls of the common people, it cannot be practical. The practice will go on unless ordinary people understand it. So as I said it beforehand, all the mohalla clinic, all the dispensary, DGHS dispensaries, other CGHS dispensaries, they allow ordinary people to come in and get medicines. When those people come, it should be made a law that the doctors treating to them, maybe for some other thing, they should always check them for the cancer also, and tell the patient, we went to Mathura, people were not talking about cancer. Then we stopped using the word cancer. I just started asking those women, do you feel like this? Like all the symptoms, I said, like some disease. Okay, do you have this? Do you have extra bleeding? Do you get pain? And does this happen? When did you get married? When did you? Then she started, women opening up, I have pain, I have extra bleeding, this and that. And then said, it is very important for you to be checked and treated. But I never said checked for cancer. So if a woman comes for other things or a man comes for other things, the doctor should check for cancer also, maybe oral cancer, prostate cancer, pap smear for this. So if they do that in every mohalla clinic, so it will reach out to more people. Few people cannot reach everywhere. So there has to be a chain right from the grassroots level to above. So you make it compulsory for the GRCs, for ASHA workers, the health providers of the area. Parivar Niyojan, we have got healthcare providers also. So they should make it mandatory for those people to check the people for cancer as well, and ask the people that it is compulsory for them to go for this test, otherwise they will not get the medicine. Now these people will go for the test only if you stop giving them some medicine. When they come for screening with Indian Cancer Society, we go for screening. They said, "आप दवाई दे दोगे? तो अगर आप दवाई दोगे तो हम टेस्ट कराएंगे, नहीं तो नहीं कराएंगे." They don't know क्या दवाई मिलेगी, क्या नहीं मिलेगी, but they should get something free, So these people can be, and then they trust the doctor more than they trust us. If the doctor says it is compulsory, then they will feel yes. If I go and tell somebody that you should go for pap smear, it is compulsory, they say because she is a social worker, she has to say it. So they won't listen to me. But if the doctor says it is mandatory, they will do it. So we should start working from the grassroots level, not at the ministry level, keep discussing big things and big money and big everything. And if we should nip the evil in the bud wali baat hai. And then we have to bring behavior change. वो कहते हैं ना, नजर को बदलो नजारे बदल जाते हैं, सोच को बदलो सितारे बदल जाते हैं, कश्ती बदलने की जरूरत नहीं, दिशा बदलो किनारे खुद मिल जाते हैं. So we have to change the attitude of the people towards cancer, and right at every level. We should not work on cancer on a higher level only. We should at every level, in the small jhopdi colony also, we should have at least one person who is made aware, and whose duty that when it is she or he is there, make aware each and everyone. So that will bring down the number of cancer patients. If not the number of cancer patients, at least curable patients will be more, and the people late coming patients will be much less. So our first level should be that, which I think is doable if all the stakeholders work at their own level, right from the bottom till the top. Thank you.
Thank you, Rekha ji. Very important point. So you are talking about utilizing the whole public health cadre available, which is there to start picking up the signs of cancer or any other critical disease early, so that there can be the faster diagnosis of it, and also the care can also be ensured. Let me go to Dr. Ravi Mehrotra. And also you have very importantly highlighted that we need to work at the grassroots level using our existing resources, and have to go on a campaign mode and normalize the cancer discourse. It should be a normal discourse like we do for many other diseases. The diabetes is a very normal discussion at every family, despite the fact that you can never get cured of diabetes. Heart care has become quite a normalized discourse in families, despite the fact that it do kill a lot of people. So let me go to Dr. Ravi Mehrotra, and the quick one I would try to wrap up in next 5 minutes. So Dr. Ravi Mehrotra, what is your take that how we can, from the whatever resources are available, what can be the possible linkages, some workable solution, so that the existing resource itself can help us kind of tackle this problem relatively in a better manner?
Well, what I suggest is, aside from the financial resources, we have a tremendous human resource in our country. I mentioned earlier, catching them young. I still feel, I actually talked to the education minister of the country some time ago, that schools, we talk about hygiene, no doubt, but we never talk about tobacco, we never talk about cancer. I know it is not a very pleasant topic, especially when you are all of 10 to 14 years of age, but knowing that this is a part of life, even they said, well, we don't have space, we have too many other priorities. I said, well, even the back page, the inner back page of your textbook would have small pictures. Nowadays, the younger population, or even probably my own generation now, we hardly read anything. We see videos, we see pictures, and we see infographics. So having infographics like that, I think starting from a young age, if we can do that, and other countries have started doing it with mixed success, but I feel in this country, you'll be surprised, the newspaper distribution, if you look at the world, the highest selling newspapers are actually still in India. People are still reading. It is not that everybody has moved to videos only. So if we start an education campaign from the school onwards, and as Rekha ji has also mentioned, when every doctor or healthcare worker talks about early diagnosis, not only, and many are lifestyle diseases we talked about. So not only tobacco, but food, exercise, these are related to diabetes, cardiovascular, to cancer also. So that would have a kind of a snowball effect, that it will actually help in reducing all the major non-communicable diseases, which are, forget the COVID for the moment, but COVID will come and COVID will go, but non-communicable will continue to increase. So the government also has actually started the program, which is the National Program for Prevention of and Treatment of Non-Communicable, including stroke, cancer, cardiovascular, as well as diabetes. So that is where I feel we should be talking about. And we have so many oncologists here, and I'm talking about NCDs, but I think all are related to each other. And a shotgun approach is probably going to work. It will not happen today, as Dr. Sudeep also mentioned. If you talk a cervical cancer vaccine, it will start taking effect 20 years later. But countries like Australia or many in Europe and Scandinavia, they started 10, 15 years ago. Already the potentially malignant diseases of the cervix has gone down. So, I will not go into the politics of and the financial part of HPV vaccine. Hopefully that will be sorted out sooner rather than later. But prevention, and prevention is the answer. And research, appropriate resources being put into it. Although we are spending less than 2% of GDP, but even that amount is a huge amount. And do you know that even the 2% is not actually spent? So much is returned at the end of the day. So appropriate, judicious, And expedient expenditure is what is really important, not only in money, but also in human resources. Thank you.
Thank you so much. And I think that is also important from the families and the individual point of view also, that whether people are making appropriate investment expenditure, spending in their health, by ensuring it, by making sure that they are having access to the better part or the better elements related to nutrition or related to the other aspects of life. Let me quickly go to, and Dr. Abad, I will come back to you for this point. For you to highlight that. Let me go to Dr. Sonali Dige, and it's a last round. So, Dr. Sonali, you were mentioning about that one of your major efforts and endeavor is to ensure that we have faster access entry of innovative drugs in India, and at the same time, once they are in India, how they can quickly reach out to the people, the patients, and many other activities your company is doing, maybe patient support programs and other activities to facilitate it. What are the challenges you are facing on that, and also what you think can be a probable solution for ensuring that the boon of the modern medicine or the latest research can reach to as many people as possible, whether it is from from the kind of backing of the private insurers, or maybe even the government adoption of these diseases. What is your probable solution you see in this framework?
Thanks, Kamal. I think there could be a number of points, but maybe I'll just cover a few points. First of all, I think when we think about improving access to medicines for patients, a partnership between the industry and the hospitals, industry and government, are going to be extremely important. Whether these partnerships are for diagnosis of the patients, whether these partnerships are for, say, research, clinical research, or whether this partnership is to actually saying that, okay, this is a rare disease, hence government will give some more focus to this rare disease, and that will also include resources. So, the part about public, private, and anything else that coming together for cancer treatment is going to be extremely important going ahead. When I hear the conversations, the conversations are majorly focused on what doctors are doing along with government. But I think one big pillar that we are missing out is industry. And wherever we can partner with the industry to improve the policies, improve the bringing new medications, seeing to it that these medications reach the farthest of the places in India, the partnership is going to be important. And I think that is where we need to be. We need to improve upon as we go ahead. The other part, I would say, these partnership will also help. Would also be to really see. I know there is a cancer registry. However, beyond cancer registry, what kind of data that's coming up, and it's really important to again have these collaborations to see how, say, NCG, how are the different guidelines of NCG working? How are they improving patient outcomes? What is the gap that is still there in the patient outcomes? Where is it that industry needs to further work to improve the patient outcomes, improve the patient results? And that is what we would want to go and give back to our R&D unit and say that this is where we see the gap, and can we work on this to see to it that we can improve the patient outcomes end of the day. So it will have to be a complete ecosystem rather than 2-3 different pillars working completely separately. And I hope going ahead, and we know that in some of the developing countries, this ecosystem works extremely well. I hope this ecosystem will work in India as well, much better than what it is currently.
Thank you so much. Dr. Sonali, and it's a very important point that how we can engage with industry and ensure that there is enough access, and also a lot of collaboration, how the government and industry can work together for ensuring that whether access for care is available. Dr. Vaid, you wanted to make a point, so quickly you can make, then I close it.
Thank you for giving that opportunity. You know, the American model, where what they did, they connected all the university hospitals, university research labs with major academic centers. So the two worked in unison. We have a great opportunity in India to replicate the same model. There are 37 CSIR labs in India. They are doing a phenomenal work, both at the grassroots level. Research, a lot of path-breaking research, but all that ends up only as a research paper which is published in one of the journals, never transforms into a medicine or never transforms into a therapeutic idea. Connect these 37 CSIR labs with big hospitals, Tata Memorial Hospital, connected with the other academic centers, so that the cutting edge research can go in there. And a small pie, 1% of the CSR fund could be gotten into these ventures, which are joint ventures between the academic centers, the research centers, the private centers, and just 1% will make the difference, will bring a lot of data, a lot of new research into India. There are 37 such labs doing a phenomenal work in their own silos, which the outside world doesn't even know what is happening inside. It will transform the research in India.
Thank you so much, Dr. Vaid. Research is also very, very important aspect, and when we have such a kind of capability already there and not getting utilized enough, I think that these are the loopholes, or these are the gaps which need to be plugged in. I just try to wrap up what major highlights and the points you all have made, and we understand, and all of us have reiterated it, that cancer control is a complex problem, but it also has its own unique proposition and possibilities as well, and it is important that we look into a framework which is not just focusing some sides of it, or rather we have a holistic approach which includes your universal prevention, screening, so that we can pick up the early signs or early diagnosis of the disease, improving access. So just screening or early diagnosis will not help. So we need to improve the access. If we know, or if somebody gets to know that he or she has an early stage or mid stage of cancer, what are the possibility of the access of care available, and the whole kind of ecosystem has to work behind it. The cure should be there, and at the same time, as we all know, we can't save each and every patient of cancer. There will be mortality, there will be deaths, so we also need to ensure that we have enough support system for palliative care as well. For all this, what major points you all have reiterated is that from the people point of view, where we need to realize and act now, practice healthy habits, inform to the others, and defeat cancer. The other very important aspect of it, which is from the provider side of it, which we had the last round of this kind of inputs which we got, is which highlights that we have to kind of recognize as a healthcare providers, as a healthcare policymakers, as a industry, as a academia, we have to recognize and ensure that we are putting enough energy, resources in awareness, in forging right kind of partnerships for ensuring that the things are not working in silos, and at the same time also need to improvise and decentralize the care which is available, so that it can reach to the last man in the kind of row, a last person in the row, and then only we may be able to defeat this kind of a complex problem. And this again, interestingly sums up in a same word: rapid. Recognize, awareness, partnership, improvise, and defeat the cancer. So with this, I sign off for today with a hope that we soon, all of us who are caring or who are concerned for the health of the people, and also more than that, who want to save more life from this disease, to come together for a rapid approach where we are able to institutionalize all these aspects which we talked about. So thank you so much. We will be having some more discussions tomorrow on the World Cancer Day, on the second day of Cancer Summit. And with this, I thank all our speakers today who have been instrumental in sharing this wonderful insight about how we can tackle this pandemic of cancer. Thank you so much.
Thank you very much.
Thank you. Thank you.
Thank you.